be a leader also in reflecting how to act effectively to protect mental health, especially for those who have experienced trauma. We are meeting under the auspices of the Polish presidency of the Council of the European Union. Already in 2023, the European Commission underlined the meaning of the mental health and emphasized that it is connected to many areas of public policy, from education and research, through urban planning, employment and culture, to the environment and climate. The country health profile report prepared by OECD and Eurobarometer's survey clearly show that pandemic, war, and climate and digital crisis have left a strong mark on the mental health of Europeans, especially children and young people. Yet, half of those in need don't even seek help from a specialist. I believe that this is the greatest challenge for mental health professionals. We must create a space of trust and comfort for everyone residing in our country or more broadly within our European community. We can't prevent all sources of trauma, but by using the results of our research, the knowledge we can share, and our ability to collaborate, I believe we can provide more effective ways to help the trauma victims. And we can try to build resilience, especially in the most vulnerable. We can't vaccinate anyone against the effect of trauma, but we can achieve the effect similar to that of vaccine, mitigating the course and reducing the negative impact of trauma. Our role is to develop such mechanisms to strengthen resilience. I wish that you leave the Medical University of Gdańsk with the conviction that together we have taken another step forward in that direction. I wish you a fruitful meeting and joyful time in Gdańsk. Thank you.
Thank you, Professor Żaczek, for the welcome address and also for the support in organizing this conference. And now we also invite the co-host of this meeting, Director of the Department of Social Development, to speak on behalf of Aleksandra Durkiewicz, Mrs. Katarzyna Zieman. Please come in.
Ladies and gentlemen, dear researchers, dear academics, dear students, participants of the Conference of Trauma in Mental Health and of the 6th International Summer School of Public Mental Health. On behalf of our Mayor of Gdańsk, Aleksandra Durkiewicz, I'm honored to welcome you to our beautiful city of Gdańsk, the city of freedom and solidarity, where the community shows that social engagement is an important aspect of citizenship and responsibility for one another. This resilience also shapes the city's attitudes and actions in the field of health prevention programs and especially mental health. Above all, prevention, rapid support in mental health crisis, and unique programs, this is how the city is committed to continuing the Mental Health Protection Program for 2024, years 2024 to 2026. The program was created for people of all ages struggling with various problems, disorders, and mental illnesses. The first program was introduced by the decision of Gdańsk City Council in 2016 and has been updated and adopted to new needs and everyday challenges. Its continuation for further years focuses in particular on supporting children and young people, their parents and carers, based on diagnosis and taking into account the current needs of the residents of Gdańsk. Tangible evidence of these activities of this Gdańsk Mental Health Program are youth clubs, which for several years, together with non-governmental organizations, business partners, and with the support of international funds, are continuing to grow in our city. These are two Blue Sneakers clubs in shopping forum like Forum Gdańsk and Metropolia, and another new youth club, Arbus Youth Club, in the Dolna Brama Center. Why we are doing this? Even before COVID-19 pandemic and the Russian aggression to Ukraine, the mental health crisis was one of the greatest social challenges in Poland and in Gdańsk. Research results show that our emotional condition is not good, and mental health is, after all, the key to building a community, which is why Gdańsk is involved in creating such support. Since 2016, the city of Gdańsk has allocated over 20 million Polish zlotys on psychological support, and these funds continue to grow. The data indicate a continuous increase in the number of mental disorders occurring among people around the world. According to the World Health Organization, 1 in 8 people worldwide lives with a mental disorder. In Gdańsk, over 30,000 people benefited from various forms of health services every year. Psychiatric care, including almost 4,000 young people. I believe that this conference and the next few days will bring further recommendations and exchange of knowledge, experiences, and ideas on effective strategies for responding to trauma in public health system, which we will jointly use and implement in Gdańsk. Have a good conference. Thank you.
Thank you very much, Mrs. Zeman. We are very happy that we live in such a wonderful city, and the weather is such shiny today. So I now invite to give a speech for Senator and Secretary of State at the Ministry of Health, Dr. Wojciech Konieczny, who is responsible for public health and mental health in the ministry.
Thank you very much. I have honor to welcome you to Poland on behalf of Izabela Leszczyna, Minister of Health. Welcome. We are glad to see you here in Gdańsk. I would like to thank you for the invitation to participate in the conference Trauma-Informed Public Health Approaches to Resilience and Trauma-Informed Public Health. Considering the temporary challenges to mental health and the impact of the individual's traumatic experience on society as well, please accept my appreciation for your work in organizing such an important conference, with the participation of many distinguished experts and taking action on such an important topic. Trauma is understood as a reaction to a stressful, painful experience that exceeds the individual's ability to cope and causes long-term emotional problems, affecting psychosocial functioning, difficulties, and fulfilling social roles, family functioning, or work. Until recently, the public health system did not have centers dedicated to therapeutic interventions aimed at people with experience of trauma. However, in view of the contemporary challenges to mental health, a pilot program was launched to test in practice the effectiveness of different programs of therapeutic interventions related to helping people after difficult experiences, such as participation in war refugee experience, experiencing or witnessing physical, psychological, or sexual violence, being involved in a traffic accident, or experiencing the effects of a disaster. The period of the pilot was established from the 1st of January 2023 to the 30th of June 2025, but work has already been undertaken to extend it to 30th June 2026. A total of 7,626 patients were enrolled in the pilot program, including 1,280 patients aged 21 years or under. The program is implemented by 14 entities that provide staff consisting of the psychotherapist, psychologist, and psychiatrist. In addition, at least a half of the number of people included in the staff have documented training that includes a treatment program for people with experience of trauma. The coordinated work of professionals allows the identification and appropriate forms of support for the patient, who receives comprehensive and diverse assistance. The results of the pilot program confirm the need to improve the quality and effectiveness of the way in which care is organized for traumatized patients. The treatment process for these patients is lengthy and often requires a combination of different forms of interventions, targeting different aspects of the difficulties experienced by the patients. Trauma therapy should be universally accessible, with the need to develop uniform standards for diagnosis and treatment. The mental health of citizens is a key element without which we cannot speak of individual well-being. So ensuring comprehensive and effective treatment of mental disorders, including trauma, is one of the key areas to contemporary public health. Thank you for your attention. I wish you fruitful discussion and good days in Gdańsk. Thank you very much.
Thank you, Minister Konieczny, for joining us, especially from you managed to come a long way from Częstochowa and to come to us, so I really appreciate your effort for being with us. And now I invite Violeta Tomczak, Vice President of Parliamentary Commission of Health. And just to mention, Violeta Tomczak is the first and only Master of Public Health alum in Polish Parliament. Violeta, zapraszam.
Ladies and gentlemen, szanowni państwo, pozwolę sobie mówić w języku polskim, w którym czuję się o wiele swobodniej. Po pierwsze, dziękuję bardzo za zaproszenie na dzisiejszą bardzo ważną konferencję. Zaproszenie, które jest dla mnie dużą przyjemnością, a jednocześnie przyjęciem takich mocnych zobowiązań z 3 powodów. Po pierwsze, dzisiaj omawiamy bardzo ważny temat traumy, który jest częścią dobrostanu psychicznego, a ten z punktu widzenia zarówno mojej działalności społecznej, jak i naukowej jest niezwykle istotny. Po drugie, z tego powodu, że właśnie odgrywam taką rolę, czyli obecnie jestem wiceprzewodniczącą Sejmowej Komisji Zdrowia, posłanką na Sejm, a po trzecie, że to w mojej macierzystej uczelni na Gdańskim Uniwersytecie Medycznym zorganizowano to spotkanie, za co bardzo serdecznie dziękuję kierownikowi zakładu, w którym nadal pracuję, czyli Zakładu Zdrowia Publicznego i Medycyny Społecznej. Szanowni Państwo, troska o dobrostan psychiczny jest niezwykle istotna, a z kolei trauma posiada swoje źródła, które są bardzo mocno zróżnicowane, jednak bardzo często są wspólnym doznaniem, bez względu na geografię, język czy też historię. Dzięki postępowi nauki wiemy o traumie z każdym rokiem coraz więcej, ale wiele wysiłku jeszcze przed nami, aby właśnie tę wiedzę wykorzystać systemowo. Pracujemy w Sejmie w Ministerstwie Zdrowia, Państwo pracują na różnych uczelniach, za co serdecznie dziękuję i właśnie chylę przed Państwem czoło. Jednocześnie angażując w tę pracę ekspertów, angażując w tę pracę praktyków z organizacji pozarządowych, co ważne pacjentów i pacjentki. I chcielibyśmy, aby państwo polskie stworzyło skuteczne mechanizmy prawne ukierunkowane na wspieranie osób, które doświadczyły traumy, umiejętnie dobierając narzędzia pod kątem źródła traumy i specyfiki potrzebnej opieki. Tak jak w innych obszarach medycyny mówimy o terapii celowanej, tak w obszarze opieki pourazowej potrzebujemy tego samego podejścia. Życzę Państwu inspirujących dyskusji i tak naprawdę właśnie przekazywania tego tematu dalej w tym aspekcie, by został holistycznie zaopiekowany. Odporność psychiczna naszych dzieci i młodych ludzi w naszym społeczeństwie opiera się przede wszystkim także na nas, na tym, co właśnie my wypracujemy. To my dajemy słabszym siłę, a w tej sali widzę dziś najlepszych ekspertów od tego, jak zrobić to skutecznie i wspólnie. Serdecznie dziękuję.
Thank you very much. And now, on behalf of UFA, I invite Professor Tit Albrecht, President of UFA, and also National Institute of Public Health, Ljubljana, Slovenia. Please, Tit.
Thank you very much, Łukasz. Thank you for the invitation. Thank you, Jutta, for organizing this important event together with our dear colleagues from Gdansk and with distinguished guests. It is my pleasure to welcome you to this event as the president of the largest European Public Health Association that joins national public health association from across the entire region of WHO Euro. So we are here in the heart of the region, and we are facing a challenge that is not new, but that in the past was often addressed by people had to address it or face it by coping themselves, the way they managed, the way they were taught, or they were not even prepared. I would like to give you an example how an intervention that we did in my own country on an event that is drastic, but far from being so drastic as wars and mass aggressions. Some of you may know that about 2 years ago we had landslides and massive floods in our country as a result of 36 hours of incessant rain. And some regions were really severely affected. There were just a few lives lost, but many people lost literally everything. They have seen ground movements take away their houses, their property, their animals, everything they lived for and they worked for decades or maybe even generations. We went on ground with mental health support because it was super traumatic, and it was really welcome. It was welcome not only because somebody cared for people, but because it was also professional in the sense of mental health support for those people who really needed more than just a warm hand or a hug and so on. I think that mental health is one of the cornerstones of health in modern societies. We cannot separate it or put it in a separate basket and say, well, this is a separate issue. We have seen this with the pandemic. We have seen this with wars, military aggressions. We see that with victims of interpersonal violence, after all, which we shouldn't forget as well. Marital violence, intergender, sometimes even intergenerational. This is all important. And in the cases when children are affected, I feel very strongly about that. Children, of course, will carry the trauma for their entire lives if not managed properly. And I think all of you who work in this area work in a very commendable and highly important field, and we will all be looking forward to your recommendations, to your findings, to working together with you so that we contribute to what we defend, the well-being and health of our populations in its integrity. Thank you very much.
Thank you, Tit, for very important words. We cannot separate mental health from other health issues. It was very important. And ending our welcome addresses, I invite Professor Jutta Lindert, President of Mental Health Section in UFA, initiator, actually, of this conference. Jutta.
Well, thank you very much, Your Excellencies, dear friends and colleagues. On behalf of the UFA Public Mental Health Section, indeed it's my great honor and privilege to extend to you a most sincere and warm welcome to this conference. We from the UFA Public Mental Health Section deeply value the shared commitment of the local organizing team with the UFA Mental Health Section and UFA to the principles of science for health and well-being, for democracy and human rights. The Public Mental Health Section now exists since 20 years. It's time to celebrate. It is time to celebrate UFA's commitment to mental health. And this conference is the 5th International Public Mental Health Conference. Previous conferences were organized together with the local organizing teams in Vilnius, Jerusalem, Zagreb, and a second time in Vilnius. From the UFA Mental Health Section, Public Mental Health Section, we try to raise awareness for public mental health across Europe from a public health perspective. A public health perspective means that mental health is not only a health topic of an individual, but basically mental health is shaped by all of us, by the neighbors and by the families Tit already mentioned. We are all responsible for the mental health of our neighbors and of our families. This is an opportunity and a challenge. And so this conference indeed is an important next step. The local organizers, Professor Lukasz Balwiecki and Agnieszka, they really made it possible, almost impossible, because we started organizing in January. So I really would like to thank you and the team in Gdansk for the amazing work you have done. Without your work, this conference would not have been possible. So I wish us all a wonderful conference. Maybe you say hello to your neighbor in case you haven't done it, because your neighbor, this is your responsibility for your mental health. Thank you.
So we ended welcome address just on time, and we are ahead of first plenary speech. So I now invite Dr. Nino Berzuli. The floor is yours.
Okay, thank you so much. Dzień dobry. This is only word that I know in Polish still, so apologies. I have to do my presentation in English, but I'm doing my best to learn. Good morning again, and Minister Konechny, Vice Chair of the Parliament Health Committee, the representative of the Mayor's Office, Chief Sanitary Inspectorate, and of course our host, Vice Rector, host of this wonderful university. It's my first time in Gdańsk, and actually this is a wonderful city, and I will be definitely back. Thank you so much for hosting us. Esteemed colleagues, public health leaders from UFA, from Gdańsk, from all over Poland and Europe, it's my pleasure to be with you today for critical discussions how we can build resilient public health system that anticipate trauma, that protects and empowers our communities and promotes healing. First of all, I would like to thank Poland and the Polish Ministry of Health for putting prevention as a key priority of Polish presidency, EU presidency. And I'm very glad and happy, and we are very honored from the WHO that we, together with the Polish Ministry of Health, launched very recently the policy brief on mental health of young people and their digital determinants, policy brief that provides 8 recommendations, policy recommendations, which addresses the environment our young people are growing up. And it is our responsibility to make them safer and healthier, and it has been already said by the previous speakers. Trauma, whether from pandemics, war, violence, environmental crisis, or systemic inequities, profoundly impacts individuals and the communities. The COVID-19 pandemic and the ongoing conflict in Europe have shown that the public health emergencies amplify trauma, particularly for marginalized groups. A trauma-informed approach shifts focus from asking what is wrong with you to what has happened to you. This perspective is critical for prevention, ensuring that we address trauma's root causes before they escalate. I think this is not working. Oops, yeah. Okay, very good. WHO-informed trauma approaches, especially WHO endorses the trauma-informed approaches, especially in the WHO Quality Rights Initiative for Mental Health Services, guidance on violence against women, psychological first aid manual for emergencies, widely used definition of trauma is that the trauma results from an event, series of events, or set of circumstances that is experienced by individuals as physically or emotionally harmful or life-threatening, and that has a lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. There is a broad range of traumatic experiences that the public health systems must be prepared to recognize and respond to it. It is war and the conflict trauma that includes both indirect and direct trauma, and these experiences can result in long-term PTSD, anxiety, and intergenerational trauma, war-related experiences, and these forms of trauma often carry additional layers of stigma, social exclusion, especially when services fail to meet the needs of survivors sensitively. Natural disasters generate both acute stress and long-term trauma, of which we unfortunately have increasingly seen in Europe and globally. Medical trauma, that includes trauma from the experience of illness itself, but also the treatment-related trauma, which is sensitive and a vital area. And what is important to remember is that trauma is not only limited to extreme events. It is embedded in the social determinants, institutional experiences, and health inequalities. And as public health professionals, we must shift from reacting to trauma after it happens to recognizing and preventing it at all levels of care. Understanding trauma statistics is crucial, very important for developing trauma-informed public health strategies that addresses both immediate and the long-term needs of affected population. The global statistics show that the 70% of individuals experience a traumatic event at least once in their lives, but not everyone develops the PTSD. Among those exposed to trauma, about 5.6% go on to develop the PTSD, and this highlights the importance of identifying at-risk groups and building resilient support systems. In Europe, around 66% report trauma exposure with annual PTSD prevalence of 1.1%, that lower than the global lifetime figure, reflecting the variability in exposure type, health systems, and the cultural context. And Ukraine, of course, presents a special case due to the war. In the first 9 months of 2024 alone, more than 50,000 children sought mental health support, triple of 2023 figure. And this data underscores how humanitarian crisis can lead to surging mental health needs, especially among children. Key findings from the recent study on psychological impact of the war in Ukraine, especially among refugees displaced to other European countries, show the scale of trauma is profound. A large study of nearly 5,000 Ukrainian refugees in Poland found that 47% met the criteria of probable PTSD, and these are not isolated cases. The study also examined the predictive factors associated with PTSD symptoms. War-related trauma was the most obvious, but equally important were intolerance of uncertainty, loss of control, post-displacement. These findings are a reminder that the trauma does not end at the border. It continues through the displacement experience and integration challenges. Another study in Denmark, which assessed nearly 7,000 Ukrainian adult refugees, found that 15.9% met the criteria for PTSD and 13% for complex PTSD. Risk was significantly higher among women, those who had lost the family members, and people with higher education, again, likely reflecting disrupted roles and the greater awareness of loss. Public health response to trauma has been traditionally, historically reactive, crisis-driven, mobilizing the resources post-crisis, focusing on treating symptoms after they appear. While rapid response is essential, prevention mitigates the long-term effects of trauma. The WHO's Health Emergency Preparedness Response and Resilience Framework and the WHO European Region Preparedness 2.0 plan guides this shift. The WHO Preparedness Framework offers a foundational structure for building public health systems that can anticipate and respond to the emergencies. Preparedness 2.0, which was adopted by all member states last year at the Regional Committee of WHO Europe, emphasizes the resilience, multi-sectoral coordination, and community engagement, aligning with trauma-informed principles to prevent re-traumatization and foster trust. It strengthens the prevention model by calling for inclusivity, learning systems which are fully compatible with trauma-informed public health approaches. This means that we should not just treat trauma after a disaster or any traumatic event, but plan for it, embed it in the early response systems, train personnel, and evaluate systems with trauma outcomes in mind. When it comes to how to apply trauma-informed strategies, WHO guidance and existing preparedness frameworks are very clear. Countries should integrate mental health and psychosocial support services into all levels of planning. Training across disciplines should create a shared trauma-informed language and coordinated response. Exercises and simulations should include psychosocial scenarios, not just logistics. Risk communication must account for past trauma, mistrust, and cultural context. This approach fosters resilience, equity, and the long-term recovery, aligning with WHO's call for inclusive whole-of-society approach and the whole-of-society preparedness. I want to bring some of the examples of the trauma-informed public health approaches from the European region, from the European countries, but these are just a few, and I'm sure during the panel discussion today there will be much more experience and the lessons that will be shared by the panelists, how the countries are putting an efforts in implementing the preventive measures that the trauma-informed public health approaches. Finland's open dialogue model offers an example of trauma-informed crisis response, which is embedded in the public health preparedness. It recognizes that the cohesive treatment can itself be traumatic. Instead, open dialogue provides immediate relational and the community-involved care. It addresses psychiatric crisis as a shared meaning-making process, not a medical emergency requiring confinement. France's right to be forgotten policy is a trauma-informed public health measure which is rooted in the social justice, and it recognizes the cancer survivors often faced prolonged discrimination and anxiety, especially in insurance and the employment, and this law reframes the survivorship as a right to recovery without lifelong social penalties. I want to put the spotlight and all of us to have put the spotlight on Ukraine, which provides a real-world and a real-time example of trauma-informed public health conditions under conditions of ongoing conflict, under conditions of the incredible pressure that the public health system and the health system is facing. Since the full-scale invasion in 2022, mental health needs have surged, with children, displaced families, veterans, and the frontline workers being particularly vulnerable. Recognizing this, Ukraine launched a national mental health and psychosocial support initiative led by First Lady with support from WHO, UNICEF, and local partners. The campaign, How Are You?, raises awareness, normalizes seeking help, and connects people to resources. Rapid training of over 12,000 frontline healthcare workers, teachers, and the first responders is trauma-informed psychological first aid, establishment of mobile mental health and psychosocial support teams, especially for hard-to-reach and war-affected communities, integration of mental health into schools, into workplaces, into hospitals and community shelters, including hotlines and the online services, are the key feature of this campaign. This campaign is one of the largest trauma-informed mobilization in a European war since the World War II, having high-level political commitment and cross-sector coordination, inclusion of civil society, NGO, the private sectors, and a clear emphasis on resilience, on cultural competence, and right-based care. Of course, challenges remain, with the services often being overstretched, especially near the front lines, long-term mental health interventions still being developed, and specialized trauma care and the long-term PTSD treatment still lacking in many areas. But Ukraine efforts reflect a practical and scalable trauma-informed public health model grounded in the WHO's recommendations, even as the emergency continues. Dear colleagues, I want to summarize with this slide the WHO's, the World Health Organization's recommendations and the consolidated guidance on the proactive public health systems for trauma that comes from the different technical documents, different guidance documents and recommendations that when integrated offer a clear framework for building trauma-informed, proactive public health systems. This slide offers this synthesis, and I want to emphasize, I want to go through the key pillars of this approach. WHO emphasizes the importance of anticipating mental health impacts, not just responding after they arise. Importance of early detection and the surveillance. Risk assessment, early warning system should include psychosocial dimensions, especially during emergencies. Tools like Mental Health Action Program, MHGAP, help provides frontline providers with the capacity, with the skills to screen for psychological distress. Countries are encouraged to embed trauma indicators like PTSD symptoms or psychological stress into routine data information systems. This helps to track population-level trauma and tailor support proactively. Integration is at the core of the WHO's approach. MHPSS must be embedded in primary care rather than siloed or delayed. WHO advocates for task shifting, where non-specialists such as nurses, lay counselors, or community health workers are trained to provide trauma-informed care. Trauma-informed system starts with trauma-aware workforce. WHO promotes training for healthcare providers, first responders, educators, and social workers in evidence-based psychological first aid, cultural humility, safety, non-stigmatizing, rights-based approaches. This ensures that the care is delivered with dignity, with empathy, safety, especially during the crisis. Communities, they are co-creators of services. WHO recommends partnering with faith leaders, local NGOs, survivors groups to design culturally grounded supports. People with lived experiences of trauma should be at the table, not just as patients, but also as planners and evaluators. This builds trust and helps systems to respond to real but not assumed needs. Legislation can either support healing or deepen the trauma. Laws that protect mental health rights, reduce coercion, and support voluntary consent-based care are very important. Trauma prevention and recovery should be explicitly included in national health and emergency preparedness plans. And healing must extend beyond the clinical settings. Trauma literacy is a very important component of the trauma-informed public health approach, because it identifies trauma, understands its effects, and seeks help. Campaigns like Ukraine's "How Are You" normalize this conversation and reduce the shame. And this is very important. Public understanding is essential to reduce barriers to care and build resilience in a societal level. And none of this, of course, is possible without the resources and coordination, the multi-sectoral coordination. Dedicated funding for the MHPSS services, ideally as part of the universal health coverage. Trauma-informed care must be also coordinated with other sectors like justice, education, housing, child protections, and the environmental sectors, because trauma does not start or stop in the clinic. Together, these components form a blueprint, WHO-informed and endorsed blueprint for transforming public health systems from reactive responders to proactive, healing-centered institutions. And this approach is not just about treating trauma, it's about redesigning system that prevents it and promotes equity, safety, and the dignity for all. Thank you so much.
Thank you, Dr. Berzulli, for this wonderful presentation, very informative, and this summary on recommendations of the WHO really shows in which way we should organize our system. And now I invite our invited speaker, Professor Michał Bilewicz, University of Warsaw. Professor Bilewicz is Associate Professor of Psychology at the University of Warsaw, Poland, when he chairs the Center for Research on Prejudice. He studies extensively the problem of anti-Semitism, dehumanization, and conspiracy theories. He's also an author of acclaimed book, Traumaland, Poles in the Shadow of the Past. So thank you very much for accepting our invitation. Professor, the floor is yours.
Thank you very much. It's a great pleasure and honor to be part of the conference of public health experts. It's not very common for a psychologist, and particularly for social psychologists, to speak to people who deal with basically medicine. But what I would like to present today is something which seems to be quite relevant for the research and practice of medicine as well. I would like to talk about the theme of social identity or national identity, but from the lens of mental health. The term social identity in social psychology has been developed by Henry Tashfel, a psychologist, British psychologist born in Włocławek, not very far from here. He defines social identity as the part of an individual's self-concept which derives from his/her knowledge of membership in a social group, together with the value and emotional significance attached to that membership. So basically, social identity is the part of self which is derived from being member of that group. Today, we, based on seminal research by Tashfel and colleagues, we have social identity models explaining collective action, so people's engagement in protest movements, riots, strikes, different forms of public protests. We have social identity model of crowd behavior, allowing, for example, informing policing, informing how we could understand crowd behavior during, football games or mass protests, mass street protests. We have social identity models explaining the individuation effects, social identity models of leadership, allowing to better understand the role of leaders within social groups. We have very good social identity models explaining pro-environmental actions that allow to better understand how being members of nations or groups, or how identifying with these groups can make people engage in environmentally friendly actions. And what I would like to talk today is what is known as a social cure effect, or a new psychology of health. The new psychology of health is basically psychology of health which is informed by social psychology and trying to understand how being a member of group, how being a member of nation, how identifying with your nation or with your local identity or with your community can affect and particularly improve mental health. So there is vast evidence for the social cure effect, suggesting that social identity can build solidarity, can validate and lead to collective efficacy, and we know well that efficacy, self-efficacy, and also collective efficacy can support recovery. We know also that strong identification might reduce post-traumatic stress, and there is an evidence on that found in different post-conflict areas, particularly by the group of Orla Muldoon in Northern Ireland. But also there is some evidence that strong identification with a social group does not always have positive outcomes, that sometimes it might produce stigma. If you are a member of a group which is a stigmatized group, if it's a minority group which is discriminated, then the strong identification with that group does not does not create this social cure condition, but in the end it might lead to what is known as a social curse, that it might actually deteriorate mental health. A very recent study by my former doctoral student currently working in the lab of Orla Muldoon, looking at the identities of the social identities of Ukrainian refugees in Poland, found that actually different social identities have different consequences. So she found that the stronger identification with the host society among Ukrainian refugees, so the more Ukrainians identify with the Polish society, the lower the level of post-traumatic stress. And the more possible is the post-traumatic growth. But on the other hand, she found that the stronger is their identification with the refugee group. So the more strongly they identify with other Ukrainian refugees, actually the higher levels of post-traumatic stress. This paradoxical effect of strong identification on mental health is something that we've been exploring in my lab during the last several years, where we found that even in this original definition of Tashfel, there are two different aspects of identity being mentioned. So this is a part of individual self-concept which is derived from the knowledge of being member of a social group, but there is also this emotional significance, and these are two different phenomena. And we actually found that in the literature on social identity, in the social psychological literature, there is one model which distinguishes the three distinctive components of identification. So what does it mean to identify with a social group? What does it mean to identify with a nation? It means having strong ties and feeling strong ties with other members of your nation. Yes, so people responding positively to such questions as, I have a lot of common with other Ukrainians, I feel strong ties to other Ukrainians. So basically this is this relational aspect of identification. Then we have a different aspect of identification, which is centrality, cognitive centrality of identification. So, for example, I am a psychologist, lecturer, a Polish person, a Jewish person living in Poland. These are all identifications that are more or less central for me. Particularly when I am lecturing, of course, the identity of a lecturer becomes probably most important and most central. For some people, only one identity is very central. So, for example, I might be a supporter of my football team, and this might organize my whole life. Then I'm strongly identifying with one group, so it's very central to the structure of myself relatively to other identities. To some other people, some other identities might be central. Then there might be people for whom all identities are, let's say, equally important for them, right? So centrality is a different aspect of identification. And the third one is affect. So it's basically emotion, positive emotion stemming from being a member of a certain group. In general, I am glad to be Ukrainian. Generally, I feel good when I think about myself as an Ukrainian. This is the purely emotional, affective element of that. This all constitutes strength, the human identification with a group, but you can see how distinctive are these three facets or three aspects of identification. And in our research, we've been looking on how it affects different phenomena, both in intergroup, intragroup, and mental health-related outcomes. First, I would like to show you some initial evidence that these three aspects of identity have different consequences, coming from research conducted among native Canadians and looking at depression symptoms among native Canadians. Bombay and colleagues found that actually the effects of different aspects of identity are very different. In-group affect had negative effects on depression, so the more positive those indigenous people felt about their ethnicity, the less probable would be depression among them. But centrality had opposing effect. The more central was this ethnic identity for them, the higher possibility that they will have depression, because they will get all these experiences of discrimination that their group is experiencing would become their own experiences, right? And this is a study that we've been doing looking at acculturation stress. So what is acculturation stress? This is a term coming from cross-cultural psychology and cultural psychology. This is different forms of stress that is experienced by immigrant groups after their acculturation. We've been doing a study on that among Ukrainian immigrants living in Poland. And we've been looking at different forms of acculturation stress. Acculturation stress resulting from or related to discrimination, being on guard, feeling that you might experience discrimination in different situations. Then stress related to intercultural relations, so feeling that your culture is not really compatible with the culture of the host country. Cultural isolation, feeling isolated, feeling not at home. Language skills, being afraid to speak, which is a big problem, right, among immigrants, because this, even, if you don't speak perfectly, it's better when you can express yourself. But this fear that you will be judged based on the way you speak. Then work challenges, feeling that you will be differently assessed at work, that your work will be judged by others because you are an immigrant. And we found that all of those forms of acculturation stress are higher among those Ukrainians for whom their Ukrainian identity is most central, so for whom being Ukrainian is especially important. On the other hand, we found that in-group ties, so this part of identity which is related to relations, the strong ties with other Ukrainians, they had actually a reverse effect. They were actually decreasing the acculturation stress after migration. We found the same pattern among both Ukrainian-speaking refugees, immigrants from Ukraine, and the Russian-speaking immigrants from Ukraine. We've been studying that also during the COVID-19, and that was part of the larger study among both Ukrainian immigrants and different minority groups living in Poland. And when looking at Ukrainian immigrants during COVID, we were particularly looking at, of course, anxiety, right, which was very, very often experienced, not only by Ukrainians, but also by the majority of the Polish population. But particularly among Ukrainian immigrants, we found that the effects of identification were quite evident. The stronger ties Ukrainian immigrants had with other Ukrainians, so this relational aspect of identity was actually reducing the a possibility of anxiety among them during COVID. So during COVID, this was somehow a buffer against anxiety. But centrality had a different effect. The more important was Ukrainian identity for them, the higher chance they would experience anxiety during COVID. And now two studies that I wanted to focus on, particularly looking at PTSD after the full-scale attack of Russia in 2022, and these are the results of studies among Ukrainian refugees in Poland. And here we were analyzing the scale of post-traumatic stress disorder, and I'm very happy that we have already heard about one of our previous results looking at the predictors of PTSD among the Ukrainian refugee population. So today, using the same panel, we came back to Ukrainian refugees in Poland, but before that, we actually did a study in Ukraine. So we studied Ukrainians based on a representative sample of Ukrainians living in Ukraine today. And we've analyzed PTSD, and we also analyzed national identification. What we found in this study is that, again, centrality of Ukrainian identity is related to PTSD. So the more important is being Ukrainian for Ukrainians, the higher chance they will gain PTSD. And we found that effect particularly among Ukrainians living in the Western Ukraine. And it's not surprising, right? If you live very far from the front line, but you very strongly identify with your nation is very important for you, then all those experiences of your nation become your personal experiences. And this ultimately might lead to post-traumatic stress disorder. On the other hand, we found that the strength of ties with your national group did not have such a deteriorating effect. And the affective part of identity, so the better people felt with their Ukrainian identity, the less probable was their PTSD. So this is a result from Ukrainians living in Ukraine today. You can see that the effect of ties are not negative, they are, let's say, neutral. There is no significant effect here. But what happens with refugees? So we did this study on refugees, recruiting almost 400 refugees from Ukraine living in Poland. And again, we assessed the post-traumatic stress disorder symptom. We assessed their level of their national identification, also looking at these three different aspects of identification. And here we found that exactly what we predicted was true, that centrality, the more important, the more central is Ukrainian identity for refugees from Ukraine living in Poland, the higher is the chance that they will have a PTSD. And you can see how strong actually is this effect from this standardized regression effect. And the effect of ties were negative, right? So you can see that different aspects of identification have completely different effects on the mental health of immigrants. So the strength of ties with other Ukrainians in Poland is actually a resource that can help in times of traumatic experiences. But the centrality or the construction of identity around only one national identity is something which might become a risk factor. So to summarize that, strong national identity might serve both as a social curse and a social cure. High national identity centrality can translate war experiences into personal experiences. If you are identified only with your national category, it is extremely central for you, so you don't think about being, an inhabitant of Warsaw, member of your community, person identifying with your department where you work at the university. Then you are more vulnerable to the threats that might harm this one group with which you so strongly identify. And this ultimately might translate also into post-traumatic stress when your group or your nation is at war. The strong ties, however, that result from national identity and positive emotions that are related to national identity can become a resource among refugees. They help them function in a host society. They can reduce the risk of traumatic stress because it's much better to function in a community with which you are connected, right? It reduces also this isolation, and this is, as you could see, also a part of the stress, of the acculturation stress in this host society. Thank you very much, and I hope that your own activities and your own actions in the field of public health can make immigrant and refugee groups create strong social bonds and make them also able to attach not only to their home country and not only to their refugee community, but also felt identified with other communities and with other social groups in the society in which Ukrainian refugees today live, not only in Poland, but also in other European countries. Thank you very much. Yeah, luckily it seems we have 4 minutes still, so if somebody would like to ask a question or give a comment on that, it's actually the first time I'm presenting this line of research, so would be very grateful.
Would you like to ask any questions regarding?
If not.
We have some time to few questions.
Yeah.
Hello. Maybe just a question. Could you stratify also socially these refugees? Were there any differences according to their social status?
Oh, I don't remember exactly now the effects of social status, and I think this question could be answered better on our previous study that has been mentioned by Dr. Bezzuli in her talk, where we analyzed more than 3,000, I think, of Ukrainian refugees living in Poland, and we looked at particular risk factors of PTSD. I don't think that demographics actually had a very profound effect then. Of course, the gender effects were missing because this was a vast majority female refugee population. It's the specificity of this refugee group. But we found some interesting and important psychological factors that, for example, post-migration discrimination experience are severely affecting or severely related to PTSD symptoms. So it's not only your experience during the war, but also how you are received in a host society that affects your mental health, basically. Mm-hmm. I think there's a question.
We have one question from the back.
Paweł Zagorza, thank you for a very interesting talk. I'm a psychiatrist, and a very interesting analysis. I would like to ask, in the light of this associations, this bidirectional association between centrality and trauma, what do you think about this solution? Maybe it would be more healthy to abandon your heritage and try to build new forms of identity when you are a refugee, for example. Thank you.
Thank you. I would never say that, because I don't think that these results actually would suggest that abandoning identity can be beneficial. Because if you abandon the identity, you lose those two main resources, which is the affective, the emotional resource that's given by your identification with your national group. And you also lose the relational one, right? So this full assimilation into a host society is not something which is, first of all, it's very difficult because of the acculturation stress. It's not very easy, basically. And on the other hand, so if there is any very practical implication of that, is that we should build more complex identifications, or allow refugees and immigrants to build more complex identifications, not only with their ethnic group, but also with their workplace, with their new environment. And this is very essential, that it's not, that we don't keep refugees or immigrants closed in their own communities without any ability of identifying with, I don't know, Lechia Football Club here in Gdańsk. I don't know. Oh, sorry, I didn't want to make it a political statement, but yeah, or any other, I don't know, sports activities or any other activities. Thank you very much.
Thank you very much, Professor Bilewicz, and thank you also, Professor Zagorza, for this provocative question, because I also had in mind that what we should do with this identity. But thank you for this explanation. We do not lose. We do not want Ukrainians to lose their identity, but to put a strength on the ties, on the links with the community. So now we move to the last part of the first session. It will be a panel discussion, and I invite now Dr. Maria Libura, who will moderate the panel, and I invite Professor Jutta Lindert, Professor Tit Albrecht, Professor Michał Bilewicz, and Dr. Tomasz Bochenek.
It's such a great pleasure to moderate the discussion after the first session. And my first question is to Professor Jutta Lindberg, and I would like to ask you about the experience of refugees in Europe and what we know about the trauma effects on their functioning within the new societies can be accommodated within healthcare systems, or more broadly speaking, health system.
Well, thank you very much for this question. I have done some studies not only on refugees in Europe, but as well on refugees worldwide. And there are maybe three main messages coming out from these studies. One message is that really mental health conditions are associated both with past experiences and with ongoing experiences. Past experiences means mainly human rights violations targeting at the integrity, security, and identity of people, and ongoing conditions, ongoing living conditions, such as the possibility to work and raise families, which means that basically maybe there should be a paradigm shift in the thinking about refugees. What we found in our studies is that contributing to mental health of refugees is giving them the possibility to contribute, to give back to societies, not seeing them as receiving help, as needing help, but really giving refugees the possibility to work, to thrive, and to contribute to the host societies. And maybe this case something we can think about, to look at refugees from a different angle, from a different perspective, not as those who are in need, but those who really can give something to our societies. Thank you.
And which also somehow relates to what Professor Bilevich was saying, right? It's, you probably need to be engaged to be able to have those many different identities which are not just related to your past experience, and the more social involvement there is, the higher chance that those centrality will be somehow lower. And maybe, if I may slightly switch from the original original scenario and direct the next question to Professor Bilevich, because you both do research on migrant health and or migrant trauma experience, and that your talk was so interesting in this respect, showing that perhaps we could somehow translate this research of how we understand trauma, both before the refugees coming to a country and after arrival, and what it tells us about the sources of trauma, both before and after arrival in the host country, and what perhaps we could do to lower those levels of trauma.
Yeah, so apart from these identity-related problems that I already discussed here, there is one aspect of migration situation which I think we will probably view very similarly, that for refugees, the experience of migration is a huge experience of powerlessness and loss of personal control. And we know how important is self-efficacy and a sense of control to basically keep mental health and this is basically an additional stressor for those otherwise, very severely affected groups that come. And we've seen a lot of that in Poland, and in this large study of Ukrainian refugees, we found that a sense of control or versus powerlessness was very much related to the symptoms of PTSD, and particularly to people with high intolerance of uncertainty. So I am quite intolerant to uncertainty, and I can understand the situation of a refugee coming to a country where they have to organize their life from scratch, right? And we remember March 2022 in Poland, right? This complete chaos in which everything was, we were self-organizing some support for refugees, but basically when you think about it from the perspective of a refugee, it's a very dramatic situation. And if you understand that those people were affected, were in the situation of acute stress, in fact, right? So just imagining that, this explains why we observe this 47% of PTSD, which is something I very rarely see. I see these numbers only in refugee populations, actually. I mean, you don't see that in survivor and war veterans. So this is this PTSD that you can find only among refugee populations that are also additionally affected by the experience of migration.
Okay, so it's actually higher, right, than in this particular group. And you, if I may focus on one more theme from your lecture, and again address first perhaps Professor Yuta about that, namely language, because you mentioned that language is key to this feeling of otherness, that if you don't speak the language of the population you live in, you stand out, right? And language is the way we integrate ourselves into. And what are the general experiences of actually helping people acquire language, but also helping the native population to tolerate different accents or the way people speak? And later I'll ask this question about Polish as well, because I think Polish.
Wow, this is a difficult question because Germany is such a huge country and it's organized in a very different way in the different counties. So basically, for me, it's impossible to answer this question because I only know for some regions in Germany, and it's like in Bavaria, it's completely different from Hamburg, where I live. So basically, it is, in Germany, it is tried to offer 1 year-long courses for refugees it's called integration courses, to help them learn languages, but besides languages, as well, a little bit of German culture. However, these courses are held differs a lot in the different communities. So the aim is to offer possibilities for people to learn, but on the other hand, really, it is different how it's organized. Does it answer your question? Or?
Also interested whether you can do something to make the native population tolerate those speaking differently. Because we've always focused on the incoming population, but very often it's also the problem with the with the natives who actually judge people for not speaking the right language. And I mean, maybe anyone's got experience in that.
Well, I thought that Utah would maybe refer also to the fact that there are dialects in Germany. So what you learn officially might not help you so much in everyday life when you communicate with people who speak a specific accent. And this is one of the problems. Although Slovenia is so small, we have regional dialects. Even when my mother was in a nursing home in the northeast of the country, the dialect is very, very strong, and she couldn't understand most of what they were saying, although she was a native. But I would say that this is, I think that acceptance is related also partly to the job that, or to the tasks that immigrants or refugees are fulfilling. When they are more vulnerable and when they are not employed, probably the level of tolerance is higher, even if they don't speak perfect language. This may change when they obtain some sort of a professional status, especially if they work with clients. And this is then the more difficult aspect. But I strongly feel what the professor was saying before. It's very difficult to find a compromise between trying to integrate and not lose identity. And I would say that I asked about the social aspects because, of course, probably the refugees from Ukraine who came to Poland are slightly different structure from those that came to Slovenia, for example. There were not so many in Slovenia. I think the maximum was about 4,000. So that's hardly comparable to the numbers in Poland. But usually when people escape from war and they seek refuge in the first country, which Poland is, it's usually for a strong desire to go back. So you do not put high on your personal agenda the idea that you are going to abandon your country. You, especially if you are from the countryside and so on, you hope that you can go back. We've seen in Slovenia, well, with the Balkan Wars, the refugees from Bosnia, for example, who were from villages, they were, of course, hopeful, also not, even if the house was going to be destroyed, that they would still go back to their land and to continue their life as before. Whereas, of course, if you are an academic professional, well, then you might simply switch to the career in the hosting country and maybe later consider going back once you realize some of your professional goals. So, and of course, in that sense, you also have more opportunities than a person who basically aims at going back when, of course, the possibilities occur. The chronicity of the war, of course, is just destroying some of these hopes, I think, for the people who initially had the idea that they might still return soon. Maybe it's a matter of months, it will be resolved, we'll go back. But when it turns into years, then you have to seek alternative strategies, and I think that your point on coping and on being in control of the situation becomes even more critical, because then you do have to have another scenario. And the hosting population, I think that given all the negative tendencies that we see around us, I'm speaking also globally, not only to the specific situation, I would say that, of course, in the context, in the cultural context, the proximity, cultural proximity, might be easier for the hosting population to accept. So the circumstances that occurred here, as Poland being a hosting country for Ukrainian refugees, was probably different, and in a way, it's not easy to say easier, but it was not, there was not such a gap than when we had the situation with the Middle East. So that's very hard to compare, because then you have a different, also a cultural gap, which with whatever our personal views are, we can be as open as we can be, but the society is structured as it is.
Thank you. So now I think that I should turn to Dr. Bochenek. Is that experience of Poland really that different because of this cultural proximity? Because we could see the first wave of migrants coming and being welcomed into families, but now, after some time, we see some attitudes changing a little bit, but also we have more and more workforce which is Ukrainian, including healthcare, and then patients complaining, for instance, that they can't understand a doctor, right? So who's employed in a Polish hospital. So what is the Polish experience, which, as we know, is evolving.
Thank you very much. I would add to what Professor Albrecht said, that it is not only cultural proximity, geographical proximity, but also common historic experience. Yes, we know the aggressor well. Yes? As historians counted, Poland fought something like 19 wars with Russia, usually coping with Russian aggression. So it's I think, quite important. And speaking about the preparation of workforce, professionals, healthcare professionals, public health professionals, I think it's very important. It's also important preparation of the society. First of all, to prevent trauma, trauma from happening. So I think that we should think and discuss trauma experiences in the context of building preparedness, resilience. So first of all, thinking how to prevent trauma from happening. And with regard to that, I think that holistic approach to training is important, something we know for decades, but now is probably more important than ever, which includes not only treating mathematics, information technologies as important, in addition to biology, chemistry, or physics in training of medical professionals. And also non-medical healthcare professionals, but also history, psychology, humanities. History, I think, is very important to understand trauma, especially in this geographical location. I liked very much what Dr. Berzuli said or presented. I mean, I paid attention to what she said about the statistics that I think 70% of global population was affected at least once in their lifetime by war. This is very close to, let's say, wisdom of local wisdom, similar to what I've heard from my mother, repeating what her parents were telling her, that everybody has to face at least 2 wars in his or her lifetime. This is the reality of Central and Eastern Europe. This was not my experience. This has been experience of my parents, and this was for my parents it was 1, but for grandparents, of course, it was 2. And same thing in 19th century, etc., etc. Doesn't matter if it was Russian, Austro-Hungarian, or Prussian or German partition. So yes, I think history is important, and probably knowledge of history should help in coping better with trauma. I think that in building preparedness, interchangeability of roles is important, and switching, task sharing, task shifting, switching from one professional role to another. This is not something which is probably being taught appropriately. Joint training of nurses and physicians, for example, to teach them how to switch from the roles when it is needed in difficult situations, mass public health threats. I think excessive specialization, which is occurring in medicine, healthcare, is something which is not good in crisis situations. So probably we should deal with that somehow. And generally, I don't want to prolong maybe, but generally I think that nowadays, especially in Poland, treating public health, I mean, finding missing links between public health and civil protection and civil defense is something very, very important. We have already we have dismantled our civil protection and civil defense, and we are building it from scratch nowadays, and I think finding a role for public health in civil protection is something really very important. And last thing I want to say is that I remember that in late 2024, ministers of, I think, of education and defense issued a letter to academia in Belgium, mainly medical faculties, asking them to rethink their curricula in order to prepare healthcare professionals, not only physicians, but also nurses, physiotherapists, etc. It could be public health professionals as well, to prepare them to tough times, let's say, and speaking closely to military conflict. And I liked it a lot, and I was surprised. Belgium, far away from Poland, yes, from Russia. And I think it's great that Mr. Konieczny is with us, because maybe he would present his perspective on that. I think it's very important to stimulate the academia to think about preparedness, of also trauma, including trauma-informed approaches to healthcare, public health, to stimulate academia about rethinking their curricula in a relatively quick time, not building new courses, which last usually like 2 years or longer, but changing the existing courses, and not only in medical healthcare sciences, basically all study directions. Thank you very much.
Yeah, it will be interesting to introduce that to Gen Zs, who are having very different expectations of what medical training and practice are about. But that brings us, and I really liked your remark that, yeah, we here in Poland, we are sort of prepared to, or we were taught that we would probably face war or military conflict in our lifetime. And I remember my grandmother telling me that every second generation goes to Siberia, so I should be prepared and perhaps learn some survival skills for that. Which brings me back to Professor Bilewicz, because your research, a lot of your famous research is on historical trauma. And I think it's part of historical trauma that I've heard those stories. How does historical trauma, especially in the context of the Polish-Ukrainian relations, affecting the integration of the Ukrainian community into Polish society?
Yeah, that's. Historical trauma is a process which is, an effect of the experiences of previous generation, and it's really interesting to hear what you say, that there is this memory of every second generation being sent to Siberia, or what you said about these experiences of having 2 wars in a lifetime, and that's quite special to our part of the world, I think. I mean, that's really the bloodlands, the Central Eastern Europe experiences. In most of our research on that, we find, again, that this is something which might lead to the sense of powerlessness, and also defensiveness somehow, so that we have no allies, that we don't trust others because we have been betrayed so many times in the past, and the sense of powerlessness which breeds different conspiracy theories and conspiratorial views about life, politics, and so on. And this might lead to problems in acculturation also, or bringing or integration of immigrants, right? Because we don't trust that immigrants might be a future potential for our society, right? And we could see that very much in the electoral campaign that just ended, where the migration question was framed only as a threat and only as a security issue, without any thinking about the potentials that are related to it. That of course, it's a trade-off, but we have to understand and to think rationally about that. And in a historically traumatized societies, there is a limited chance of thinking about such big societal problems as migration in a rational way, right? So thinking about it in terms of costs and benefits. And a very important point has been made already here about the civil protection. Civil protection, which is, again, we can frame it as part of building resilience, but also as establishing a sense of control, because people will not be panicking, right? So that's basically a sense of control that even in times of troubles, we have some ways of dealing with it. And that's something which is badly needed in our population, I think. So the fact that the civil protection has been dismantled basically in Poland for the previous years is a big tragedy from the perspective of psychology and self-efficacy on the societal level.
Self-help, yes, solidarity, self-help, part of the...
Professor Lindstedt.
Well, I will speak about historical trauma and transgenerational trauma later today. So I feel this is a very important topic, and if you say every second, well, you said it, every second generation is brought to Siberia, of course, then it resonates with really the situation in the Eastern European countries, which is different. And maybe we should think about refugees not as a homogeneous group, and about countries not as homogeneous, because refugees have very different experiences. In Germany we had many refugees from Syria. So this is a totally different group of people with different experiences. Before we had refugees from the Balkans. And all these refugees have their own context, their own histories, and their own memories in a way. Therefore, I think it is really necessary to be specific and to look at the specific group of refugees. And they differ a lot in their needs and in their competencies. And in the possibility how the host society interacts. So the host society in Germany interacts differently with refugees from Syria compared to refugees from Ukraine, because the refugees from Ukraine have much more privilege than those coming from, for example, from Africa and from other countries. So maybe we really should come back to Tit's question of social differences, because there are social differences and even race differences between the different population groups, and the darker people are, the more difficult, of course, it is for the host society to integrate, because there's more fear. And maybe we should really think about differences in the refugee populations and not look at them as totally, they are all the same. Indeed, they are not the same.
That's a great point.
If I may to add, I think it would be great to use as much as it is possible the Ukrainian experiences. I mean, the experiences of Ukrainians. So I think it's great that there are guests from Ukraine among our audience, because having more than 3 years of hot war, let's say, and years of coping with aggression starting from 2014, it builds great experience. So I think using these experiences would be very, very beneficial. Even, I don't know, maybe at the end of this session, if we have enough time, a few minutes just to share like the most important lesson for building trauma-informed public health or trauma-informed healthcare system. I wonder what they think about it. What are the lessons for the rest of Europe, for Poland, for other countries?
Yeah, so I think we should follow on this advice, I guess. But before we do, I'd like to ask Professor Albrecht once again, because I was really impressed by your lecture and the point that we need to not just think about psychiatry as part of medicine, which has slowly been happening over the few decades, but we need to integrate thinking about mental health as health without the mental point. Some of my students, when asked what they want, who they want to be in the future, the students of medicine, they will say medical doctors or psychiatrists. So there is still this division line between psychiatry and the rest of medicine, but there is, I think, an even bigger and deeper divide between thinking of health and mental health, even in the general population. So what can we do to bridge it?
Yes, I would go to the point that Professor Bochenik was mentioning, the one on resilience. My experience is, you alluded to Generation Z. I never liked these categories too much, but I have to say that now, teaching, I see that, which worries me, it's not a scientific observation, it's a practical observation that the Generation Z has very low level of resilience. They want everything happen on the spot. They want, they don't adapt a lot. They need the environment to adapt to them. And of course, if we think strategically, as the discussion was developing here, we could learn, and they could learn, a lot from refugees. Refugees had to cope, had to develop a series of mechanisms where their life was destroyed as they knew it before. And this is often necessary at a lower scale. I'm not speaking only disasters and wars. I'm speaking at the level when, you are disappointed in life, or you lose your job, or your partner dies, or something that is personally very tragic and severe. And of course, if your resilience is low, then you are going to have a lot of problems in coping even with these situations, not to mention a larger scale. If we think in the resilience of the society, in the coping mechanisms that people should develop, of course in their younger years, but some can be upgraded also later on, we should consider mental health and also the different services that support the development of healthy development in the field of mental health as an integral part of course, education, not only health professionals, because you indicated the dangers of a stigma that we... I will give maybe one example again from my country. Your northern neighbors, let's say in the Baltics, have similar suicide rates as we have in Slovenia. And for many years, this was like a mantra. Well, it's our national character and so on. Later, it was detected that it was about the treatment of depression. So the treatment of depression was inadequate. It was mostly treated with anxiolytics, which was not treating the core problem. And then we went into a public health intervention. We have now suicide rates 15 years or almost 20 years after the intervention, which are less than half of what they used to be with this intervention. So people are coping better, are facing, and when the last when COVID happened, for example, let's say this was a test of the population, suicide rates didn't decrease at all. The downward trend was continuing, which tells you a lot that people did manage to cope with the situation that was uncomfortable and that was not, they were not faced with, let's say, before. So I think that we have to build on population resilience, on mental health challenges that come in a broader sense. And of course, I think that the way we learn from refugees and also from victims of violence, we study, of course, their experiences and their trauma, but there are also experiences of how they manage to overcome some of these negative experiences.
If I may ask one more question, so what were those public health interventions that proved so effective in your country?
In my country, well, yes, good question. So one thing was the lowering of stigma against mental health intervention and opening also the minds of GPs to equip them with the knowledge to detect early stage depression and to treat it. Because of course before patients were hesitant to start treatment of mental health problems, although they are very common, as we know, in the populations, because they thought that they would be stigmatized at different levels, in family, workplace, internally, and so on. And the fact that they could solve this problem with their GP helped them out. And now we are continuing with this intervention that we are now developing centers for mental health in our primary health centers so that the threshold is going to be even lower and that the access will be open, of course, also to the general population.
Thank you. And I think we need to say, did you want to comment? No, okay. So save those few last minutes for the audience. So questions, but also comments or sharing experiences are all welcome. So would anyone like to ask a question to our panelists? So we'll run with the mic.
Thank you very much for a very interesting discussion. I have one comment. We know that refugees in the European countries have different levels of financial support, and of course it can affect the severity of stress in refugees. However, apart from financial support, I think it's very important. The willing of inhabitants of the European countries to accept the refugees, yes, as part of their community. I can say that I'm Ukrainian, I'm from Kharkiv, and I arrived in Poland 3 years ago. And of course, I still identify myself as Ukrainian, and I'm proud to be Ukrainian. However, thanks to support of my colleagues from the Medical University of Gdańsk, I also can identify myself as a part of the Polish community. And I think it's a very important issue, and the social support is a very important part which can help to decrease the severity of stress in refugees. Thank you very much.
Yeah, thank you for sharing this experience, and it also nicely convenes with what Professor Bilewicz was saying.
Thank you very much. Hi, dear colleagues. Alexei Kostychenkov, psychiatrist from Ukraine. Well, first of all, thank you for this fruitful panel discussions. Maybe just to share a bit of our experience in Ukraine, what we're building up right now. The last question was actually pretty good and wide, how to build the system for people. Actually, in Ukraine, we are going on the way to build really accessible and community-based system. So we are looking for different levels of support and different levels of accessibility. Speaking about GPs, WHO actually now working on integration of MHGAP program into primary health care, and actually almost all of the family doctors in Ukraine are currently trained on this program. Also going to specialized level of support, we now going on implementation of mental health centers on secondary level of support, so it's community-based services which working with the units of community mental health teams which supports people with severe mental health disorder. And also a very important layer of support is non-specialist support, so under the umbrella of All Ukrainian Mental Health Program, TIAC, we have resilience centers around the country, so it's not specialized services which provides psychosocial support. And actually now today I hear a lot of very similar thoughts about preparedness here in Poland, and it's really nice. Thank you, colleagues.
Thank you. Thank you for your comments. We still have time for a question or two, or a comment. Oh, there is one. Okay, just so let me run very quickly.
My name is Alexandra. I work with First Nations in Canada. So we have trauma-informed approaches to emergency management. And First Nations in Canada value culture, language, feeling of belonging as elements for resilience. So I'm just wondering what are the elements that are not medical necessarily and that are part of heritage of the history that are elements that the society naturally use, like humor or anything else that were observed in the migrants communities in Germany or in the Ukrainian community. Thank you.
Thank you. So now we have a question. So who would like to answer? Are there cultural traits that help people, you survive trauma in a better shape?
Just a few words that you mentioned humor, and of course there's vast evidence on humor and irony being actually a coping strategy, basically, with different adverse life events and a way yeah, when we think about cultural values, for example, of an ethnic group, they can also be viewed as a resource, and also historical narratives, but it depends which kind of narratives, obviously, because there might be narratives that might be themselves traumatizing, like, for example, what Daniel Bartal wrote about Masada syndrome or siege mentality in Israel, so the narrative that we are constantly victims and we will be always victims, and focusing only on the aspects of the history where we were victimized. In fact, this actually makes us more vulnerable in the future. So that's, it of course depends what kind of narratives from the past are transmitted to subsequent generations. Yeah.
Well, maybe I would like to add something, but I think it's very important. Maybe we should think about justice. So justice for those who have been victimized over the past decades, even over the past centuries. And this I say, well, as German, as a former aggressor of Poland and of the Eastern European countries, I think really justice and reparations to give back dignity which have been or which was tried to undermine by the aggressor is an important step of justice, really to restore the value the people sometimes have lost during the history of aggression.
Yeah, thank you so much. I really love that we end this panel on the theme of justice, and thank you so much for this really interesting discussion.
Thank you very much. So we are perfectly on time. So now it's a well-deserved coffee. So be sharp, 12:30, because we are connecting with Professor Molika from Harvard University, 12:30. Thank you. Dobra.
Mogę na chwilę przestawić ten fotel,
tak?
Żeby na ściance nie byli?
A, żeby na ściance to może ten, jak gdzieś tam. you like the coffee, the fruits and cakes, and you have now you are full of energy to join our second session, and we have a wonderful occasion to hear a great specialist from Harvard Medical School, Professor Richard Molika, but I would like to ask Professor Jutta Linder for a short introduction of our invited speaker. Jutta.
Well, thank you very much, Lukas. Well, Richard Molika, we have the great honor to have him as a speaker today, and it's really a privilege to listen to him. Richard is professor of psychiatry at Harvard Medical School in Boston, United States. Additionally, he was the director of the Harvard program in refugee trauma at Massachusetts General Hospital. Richard Molika, in fact, is considered a pioneer in refugee mental health, if not the pioneer. He published groundbreaking work in the field of trauma and mental health care for refugees, not only for refugees, and he set up the stage for trauma-informed care, and he is still very much involved in many countries in the world, including in Ukraine. Additionally to his professional merits, he is a wonderful person and a great friend, so I'm really glad to have you here, Richard. The floor is yours.
Thank you so much, Judith. So I can just begin now?
Yes, just begin.
Okay, very good. Well, what a great honor to be here in Poland. I'm sorry I'm not there in person, but I'd like to thank the excellencies from the government, the local organizing team from Gdansk, Professor Lesky and Dr. Wojcicka. I'm sorry I'm not pronouncing these names properly, probably. The European Public Health Association, Professor Albrecht, and of course my great friend and colleague, Jutta Linder, from the EU PHA, Public Mental Health Section, and the European Commission. Thank you all for this great honor. It really is a great honor for me to be speaking to you briefly today about this important topic. What Jutta asked me to do is to give a very short synopsis of a 40-year history, 4 decades of working with highly traumatized populations who've experienced mass violence and torture, not only in our country, immigrants and refugees in our country, but also throughout the world, you know. And just so you know, we're currently involved with our Ukrainian colleagues in Ukraine on a number of projects, especially directed at helping children who have been displaced by the war. And we are also have a 40-year history of working in Italy. In fact, we have a school in Italy, and we do our global mental health training in Orvieto. So if anyone's invited to come, and we'll be online again in full. So I'm going to try to go through these slides quickly, slowly, because in translation, it translated, and try to give you some of the highlights of this 4 decades of work. So Judith, if you can show, and Judith will show the slides for me. If you can show the first slide.
We can see the first slides, Richard.
I can't see it, no, I don't see it.
Well, the audience can see it. Maybe you can continue speaking. They are fixing the technique.
Yeah, okay. Well, in the very first slide, you see the picture of the Englishman in the first slide?
Yes.
How do we find the person behind the facts? You see that slide?
Yes.
Yeah, okay, so let me talk about that slide for a minute. So this idea in biomedicine, I'm a great lover of biomedicine. We know all the miracles that have been created by the medical profession. But sometimes going back to this attitude of disengaged reason, in other words, oh, I can see, I see it now, great, good.
Great.
That this concept of disengaged reason goes back centuries, where people were saying, forget all this drama and all this emotion about people and their lives and their history. Let's just get to the data. This is the empirical approach, what they call non-reductionistic physicalism. This is disengaged reason, get to the naked facts, get to the naked truth. But we know with highly traumatized people, people who've been through war trauma, people who've suffered extreme violence, you know, people even in our mainstream populations, domestic violence, etc., that you gotta get behind the facts to find the person. And you all know from your history in Poland and in Europe, etc., that there's a huge history behind all of us. There's a big history. History in family, history in our community, history in our ancestors. And it's important in medicine to find this history. So the next slide. So that I can see the slides very good, Drew. So in the next slide, we know that we were involved in finding the trauma-informed care movement 25 years ago, which came out of the women's movement, talking about violence in women. And I know you've done a lot of your country, and Judah and the Europeans have done a lot looking at domestic violence and violence towards women, as well as the United States. And so the mantra of the trauma-informed care movement is, let's shift away from asking the question, what's wrong with you, to ask the question, what happened to you? This is the trauma story we're going to be talking about. Next slide. So Julie, can you do the next slide?
I'm trying.
There we go. Oops, go back to the, you skipped over the humiliation. There, go before that, go to the beginning, yeah. The slide after the trauma-informed care mantra. Okay, keep going back to it. Okay, go forward now. Okay, good. What's wrong with you? We're going to pass this one, go to the next slide. The next slide, we're going to talk about humiliation. Jude's going to try to show that slide. Okay, there you go. Very good. Thank you, Jude. Good. So we discovered in our work that violence, extreme violence especially, works through humiliation. In other words, the perpetrator uses the instruments of humiliation to create a state of humiliation. And this is a very important finding because it's very hard clinically when you're working with patients, very hard clinically for people to talk about humiliation. It's so deep down, it's buried behind the symptoms of depression, anxiety, post-traumatic stress disorder. But after many years of work, we discovered that the core phenomena, the core industry, the humiliation is the atomic bomb of emotion. In other words, it's really devastating and it has a terrible impact on people. Next slide. We'll go to the next slide. It has a summary of humiliation. The next slide, Julie, thank you.
No, it doesn't work.
There we go. Okay, very good. So you can read this. I don't know if you can read this in English, but I'm just going to summarize it. Humiliation is a complex emotion, and it's characterized by feeling physically and mentally inferior, unclean, shame, spiritual worthiness and guilt, and moral repulsiveness to others, even feeling repulsive to one's God or one's religion. It's powerful, very powerful, and we have to get at humiliation. Professor Linder has been doing a study that has included humiliation, and I hope she, at the end of the talk, will speak about her research on humiliation. Very important work. So we try to get at the feeling, the deep, deep, deep psychological injury and damage caused by humiliation. That's the goal. The goal of the perpetrator is to annihilate, through humiliation, the human being, the family, the community, and even the society and the nation. It's about cultural and emotional and physical extermination. It's a terrible thing, humiliation. To be deeply humiliated is terrible, terrible state to be in. Next slide, please. You all probably recognize this. This is the mummies of Pompeii. I've used these mummies since 30 years now as a metaphor for trauma. People frozen during that terrible historic disaster in 76 AD in Pompeii, Italy. Next slide. And this is very important. There's a solidarity between the doctor, the nurse, the health worker, the policymaker in trauma, because every human being has experienced tragedies in their lives. It's inescapable. No one can get through life without having a tragedy hit them. Whether it's the loss of death of a parent, car accident, cancer, it goes on. So every human being shares the tragedies in their life. This is inescapable. But we also know, and you know this in your work in Poland, that a profound pain enters us when we realize that one human being has hurt another. This is a reality, that when one human being hurts another human being, and we recognize that, we really have deep upset. It's very disturbing. Next slide. So I want to take a minute to read this famous quote by Primo Levi. You may know his work. I knew Primo Levi. I was honored to have a correspondence with him. I also had a correspondence with Leo Eidinger, the great Norwegian psychiatrist who founded the concept of concentration camp syndrome and did some very important neuroimaging work. And in his biography of living in Auschwitz in the concentration camp, he has this very powerful dream. It's a very moving dream. where he says every inmate had this dream in the camp. He says this, and here's the dream. I will read it to you in English so it can be translated. It is an intense pleasure, physical and inexpressible, to be at home among friendly people and to have so many things to recount. But I cannot help noticing that my listeners do not follow me. In fact, they are completely indifferent. They speak confusedly of other things among themselves as if I was not there. This is a very powerful and sad and touching line. My sister looks at me, gets up and goes away without a word. And then this always brings tears to my eyes. He says, a desolating grief is now born in me. Can you imagine that? Sister walks away without listening to his story. A desolating grief is now born in me. This is what we're going to be addressing now around the trauma story. Next slide. So we know the major responses to trauma are the will to deny. People deny the traumatic life experiences of other people for many reasons. They can't deal with it, it's too upsetting. And then there are also many political reasons why people deny listening to the trauma story of others. We know that a major response to trauma is losing the world. In other words, and this is Sophocles in his beautiful play Philoctetus describes perfectly the trauma response when Philoctetus is abandoned on the island of Lemnos by Odysseus with a terrible wound that was given to him by a goddess. He's living there in agony, and when the chorus comes back, they want to steal the bow of Hercules from him to win the Trojan War. The chorus, Greek chorus says, we're a stranger in a strange land. The trauma survivor lives in another world because they've lost the world of ordinary life. No one, like in Bosnia, we worked in Bosnia 10 years in Sarajevo and in Croatia, but mostly in Sarajevo, and no one could imagine soldiers coming in and raping every woman in the house, including little girls, or snipers from the hills shooting pregnant women in the belly. This is not the world our mothers and fathers taught us to live in. So our normal world is destroyed, and we become a stranger to that world and live in a new world. I hope you get a chance to read Sophocles' Philoctetus. It's a masterpiece of psychology, and I love it. And I think we also know that stealing the bow of Philoctetus, stealing the trauma story is a common story, but we won't go into that today. Next slide. We know Michel Foucault, the great late French philosopher, said the body is imprinted by history. Our bodies carry our history. And we know that the trauma and the trauma story is in the mind, our behaviors, our bodies, and our spirituality. It's embedded, trauma story is embedded in all parts of our life. Next slide. And after working 10 years collecting the oral history of Cambodian women we discovered there was a kind of archaeology to the trauma story, and that the trauma story had 4 elements to it. These stories, these wonderful stories that oral histories that I recommend everyone to do oral histories. They're fantastic ways of learning about people's lives and their history. There's the factual accounting of the events, the cultural meaning of events, because violence is cultural, and it's done in a cultural way. If you're in Peru, Cambodia, United States, wherever, people violate in a way that is part of their culture because they know in their culture what hurts the most, what will humiliate people the most. You have the Thomas Merton, great monk, priest, wrote about contemplative prayer, and he talked about with prayer you look behind the curtain. I use this term with the trauma story because what happens is that people, when they lose their world, all of a sudden they look behind the curtain of everyday life and they see what is there that's not good. So as they have to build a new world, they have to rebuild it based on knowledge that in the old world that was destroyed by humiliation and violence, certain things need to change. Certain things need to change. If you understand what I'm saying, in other words, you see the old world that was destroyed, and you see the good parts of it, and you see the bad parts of it. You get an objectivity, and that's called looking behind the world. And finally, we have to appreciate that all of us, as listeners to the trauma story, become part of the story. We enter into the story as a listener. Isn't that amazing and wonderful? We become, whether you don't have to be a doctor. Primrose Lovely Sister could have entered into the story. We enter into the story through deep listening. We're going to talk about that now, deep listening. So what is deep listening? Well, we have a famous Italian professor, Franco Paparo, who taught me the concept of Luda. We can go to the next slide. Sorry, I didn't tell you that. Next slide, yeah. And he came up with this acronym, listening, understanding, deep appreciation. And I think there's a lot of neuroscience behind this. But deep listening really is important to listen to the trauma story. But we're getting to also, we have to listen deeply without being overwhelmed by the sadness and the violence and upset of the story. We'll talk about that in a few minutes, how to reduce empathic distress, because we know the good news about listening to trauma story is empathy. The bad news is empathy, because empathy can create a lot of distress in the listener, what they call vicarious trauma. But we also know from the neuroscience that when we listen deeply, we look at the person, we share eye contact, we affirm, we pay attention, we listen without interruption, that the brain of the person, a lot of research in this, the brain of the listener and the brain of the storyteller synchronized. They're on the same pathway. If you don't pay attention and don't listen, the brains don't match up. There's a disconnect in terms of the synchronism mentally. And we also know that the Wernicke area gets activated during spoken language, and the emotion of the story has an impact on us. And the stronger the relationship between the speaker and the listener, the stronger and more successful the conversation will be. So this is very important, deep listening, and we're going to talk about this, how to do deep listening. And it's key in deep listening to the silence is as important as the speaking. That's amazing, isn't it? In other words, through our silence and deep listening, we open up the space that allows the patient to enter into our relationship, empathic relationship and partnership. We create an invitation and open the space to share in partnership. Next slide. Next slide. Yeah. I love this picture. I just showed because I like it, and it shows isolation here on the far left, and it shows the flowers of love on the far right. It's a good metaphor for deep listening. Deep listening creates the flowers of a relationship. The next slide. And this is an interesting slide, because we know from the neurosciences again that we have to, in order to listen to the story of the patient. Look, it's one thing to say, oh, your lab work, your hemoglobin A1C is, 12, and you have high blood pressure, it's 160 over 95, it's that. But getting behind that data to the person takes a lot of work and skills, and we know it's important to create a safe place, because this is called hospitality, medical hospitality, because we know that within a nanosecond, the anterior cingulate cortex in the frontal lobes tells us immediately if we're safe and secure and we can trust this environment. This happens within nanoseconds. So as soon as you meet the patient, immediately their anterior cingulate gyrus is saying, can I trust this person? Do I feel at home here? Do I feel safe here? And that's really important, because building trust begins with the opening, hello, how are you, Mrs. X? And in our clinic, I would walk out into the waiting room and meet every patient and address them in their own language in a kind and friendly way, and then bring them into our office, which was full of plants. It was a jungle, which they loved, and they felt very comfortable and very at home talking to us, And we know that this trust is associated to oxytocin and the love, what they call the love hormone, that all these affectionate things, empathy, all of things related to human relationships, social connectedness, releases oxytocin, which makes us feel good, makes us feel loved, appreciated, valued. And this has an enormous impact because violence activates the limbic system, knocks out the frontal lobes, and has a life of its own. The amygdala takes over and controls everything through flight, fright, fear, etc., and doesn't allow our frontal cortex, our anterior cingulate cortex, to plan and to do anything. We gotta survive, and so we have to deal with this in listening to the trauma story that most of these people, their limbic system is hyper agitated. They have high limbic arousal. Next slide. So we figured out over the years how to prepare the patient. We don't talk about this much in medicine. How to prepare the patient to tell the story. Can you imagine that? Storytelling coaching. How do you coach the patient to tell the story, the trauma story? And out of this hermeneutical information, the history of the person, we have a lot of discoveries related to their lives, their medical problems, how to deal with their medical problems. It goes on and on. So if you look at this list, I'm sure you're familiar with it. So in our patients who have been through a genocide, the Cambodian patients, for example, all lived through the Pol Pot genocide. It's the 50th anniversary, by the way, a week ago. 1975 was the beginning of the Pol Pot genocide, where millions of people were put in concentration camps and killed. 2 to 3 million people out of 12 million. So to reduce the limbic system arousal, deep breathing. I discovered this in Ukraine, how important deep breathing is, because in the school system, we taught the kids deep breathing, the teachers got into it, the parents got into it, the tutors they went crazy over deep breathing. It kind of circulated through the whole community. Everybody was doing deep breathing, and it came to me that all of us, whether we're patients, doctors, teachers, parents, whatever, children, we need to learn deep breathing. Deep breathing is basic to relieving stress and to reducing the limbic system arousal. We also have a huge amount of research now on nature. The important, beautiful country in Poland, so many natural environments. Spending time in nature reduces the limbic arousal. Gardening, I don't know how many of you do gardening. Gardening is key to reducing limbic arousal. We also know yoga is a big, yoga like stretching, listening to music. This morning I got up early for this lecture, and to center myself, I was listening to the song of the early morning birds. When you listen to the birds singing, it really helps center you and helps to calm you and reduce your stress. Of course, prayer, mindfulness, meditation, healthy diet. We like to recommend patients they do a gentle swim in a warm pool. That helps reduce the limbic arousal. And then for all of these things, we write a prescription. So we'll say to our patients, instead of saying, take your antidepressant, the name of the antidepressant, we do that too, of course. But we'll say, take a walk in your park 10 minutes every day. And we write this as a prescription. Do deep breathing before and after getting up in the morning and before you go to bed at night, 5 minutes every day. Here's a prescription. follow the prescription like taking medication. Next slide. So here's a slide, one of my favorite slides. It took me a long time to come up with this, called the trauma story narrative flow. And I hope you can see here that on the vertical axis is the limbic level of limbic response, arousal. And on the bottom line is the storytelling ability. And it became clear to me that people who are highly aroused in their limbic system can't tell a story. They're unable to share the story. And you have to use those techniques I just described to move them down to the green bar to reduce the limbic arousal so they can tell their story. And also, there's a contagion between the storyteller and the listener that also a highly aroused patient will create a highly aroused doctor or nurse or psychologist, etc. In other words, we have to reduce our own limbic arousal to listen. So this shows you how we can't, we have to prepare people for storytelling. And what is the impact of storytelling? Huge impact on reducing stress, depression, anxiety, etc. And there's a tremendous, and also we know that storytelling is big on wound healing, very big on wound healing. We also know storytelling, we use this in Ukraine. We had stone soup fable, I'm sure you have this fable in Poland, and Aesop fables, and it helped the kids to begin with the storytelling in Brazil. They had a wonderful study where kids in the hospital who were told stories had less pain, less mistrust of the hospital, less anxiety, etc. So storytelling is huge in our book, and we love it, and we strongly recommend listening to the trauma story. Next slide. But you have to prepare yourself and the patient to listen. Unfortunately, in American medicine, the doctor interrupts the patient after 11 seconds. Can you imagine that? And goes right into the medical facts. 11 seconds. You have 11 seconds to tell your story. Then they go into the hemoglobin A1C and the hypertension, all that stuff. So I'm going to leave this. We have almost used up due to all of our time. I'm going to leave this pocket card for you to use. This is trauma story pocket card. We translated into Ukrainian. We used it in Ukrainian, and it's very popular, and it helps you learn how to listen and work with and use therapeutically the trauma story. So Judith, people can have these slides and they can take this pocket card and to put it in their pocket. We love pocket cards, things you can put in your pocket and just pull out and look at when you need to. Okay. So finally, with the last slide, we're getting towards the end here. The last slide is, show the last slide is, so when we opened up this Pandora's box, the last slide will show you what do we find when all the craziness comes out. Judith's going to show you the last slide here. Well, I'm happy we got this far without glitches. Thank you, too. If you can't get to the last slide, I'll just tell it. Yeah. So in the last slide, in the bottom of Pandora's box is hope. And hope is not wishful thinking. The French philosopher Gabriel Marcel, who I loved, who wrote most of his phenomenological philosophy under the Vichy regime, says, hope is fidelity to a bigger picture, faithfulness to a bigger picture that also is strategic. It's not wishful thinking. It's strategy for action. And I think, the next slides, couple of slides, are just some references that I wrote. We can't get, there you go, there's Healing Invisible Wounds, my book, next slide. And 2 manifestos based on the Italian manifesto model. So I think, Julie, we can turn it over to you for the Q&A. I hope you can say something about your work on humiliation.
Thank you very much, Professor Molika, for a wonderful and speech. I feel kind of very pleasant feelings about talking about warmth and deep conversation. So thank you very much for sharing us your thoughts, your experience, and your research. So now we have a few minutes for questions. Who'd like to ask? I maybe share some experience. Można po polsku zadać, to najwyżej będziemy mieli tłumaczenie wtedy. Oh yeah. Okay. We have a question.
Ja bardziej bezpiecznie czuję się w języku polskim, także przepraszam. Jolanta Zboińska, Fundacja Pomorskie Centrum Psychotraumatologii. Ja chciałabym bardzo podziękować panu profesorowi za ten poruszający i taki mocno wzbogacający myślenie o traumie wykład. I moje pytanie jest takie, jaki jest pana sposób myślenia? Bo powiedział pan o narracji, a zastanawiam się, mocno jest teraz obecne w myśleniu też o traumie takie integracyjne podejście, łączenia różnych metod, łączenia różnych modalności. I chciałabym zapytać o autorytet pana profesora, jak pan o tym myśli. Dziękuję bardzo.
So we have one question from Mrs. Boinska, who is working. He's a president of Trauma Foundation, and the question was regarding that you mentioned about the narrative way of dealing with trauma. But what about the integrative attitude to, when thinking about the trauma?
Well, I think the integrated, the trauma, violence, the impact of violence is in the body, the mind, and the spirit. And that has to be integrated. And in other words, the clinician has to work with the body, the mind, and the spirit. It has to be an integrated approach, and everybody can find their own model for that. But most of our work occurred in primary healthcare, in the primary healthcare sector, because of we also know the long-term impact of violence is heavy. 60s from the violence. There's a lot of research in my book. I pointed out. There's a lot. Judah can help you with this too. There's a Professor Linder. There's a huge amount of research that also people who have been through heavy violence, like in Ukraine, they need a huge public health approach to help relieve the long-term impact on them physically, mentally, and spiritually. We could talk about the spiritual part as well, because we work very closely in Bosnia and in other countries, Peru and Cambodia, the United States, with the clergy, because the four main elements of resilience in our research is social relationships, spirituality, work and education, and altruistic behavior. We write prescriptions for people to go out and help other people, to work in a food pantry, to help elderly, etc. You know, altruistic behavior is very therapeutic, you know.
Thank you very much, and we have another question.
Może nie pytanie, komentarz, podziękowanie. Agnieszka Kamińska, Polski Instytut Intensywnej i Krótkoterminowej Psychoterapii Dynamicznej Sentio. Chciałam podziękować za pokazanie właśnie tego integracyjnego podejścia w myśleniu o tym, jakie skutki daje trauma. My się zajmujemy edukowaniem psychoterapeutów i to, na co pan profesor zwrócił uwagę, taki kontakt człowieka z człowiekiem, który reguluje nas na tych wszystkich poziomach, teraz myślę o tym poziomie biologicznym, no to jest coś, z czego nie doceniamy, a to jest tak bardzo ważne w naszym podejściu. Też pomagamy pacjentom docierać do tych emocjonalnych warstw, które są za trudne do udźwignięcia w samotności, więc ja chciałam podziękować.
That was just a comment to thank you for expressing that we need this deep contact, not only on this verbal level, but also this kind of a physical connection between two people who interact in the process of healing. So thank you. That was just a thank to your presentation. And I have another question. One more.
Thank you very much. Thank you very much, Professor, for your excellent lecture and presentation. And I have a question which I think was already partly answered, but still I will pose it. What would be your advice for, let's say, resource scarce environment? Yes, because I understand you are excellent professor, a specialist practicing in Boston, USA, highly developed country. And you can provide top-notch experience and advice and help. But what about environments and situations where resources are scarce? There are shortages, limitations, not enough psychiatrists, psychologists, etc., etc. I understand partly your advice would be involvement of clergy, as I understand, social relationships, developing social relationships, spirituality, altruistic behaviors, anything else? Do I understand correctly?
Yeah, I do. Let me give you an example. In Europe, we're in Norcia, the home of St. Benedict, where the Central Italian earthquake happened 7 years ago. That's a mental health desert. There's one psychiatrist for the 5 provinces that led through the devastating earthquake, right? Our team has, Italian-American team has been there 7 years. The way we work is we first find all of the family doctors and the nurses working in the community. So in that Norcia area, there's 12. We partner with them. We don't come in and tell them what to do. We don't take on their cases, etc., because they've all been traumatized themselves. They've lost their homes through the earthquake, etc., you know. We did the same in Cambodia. We first build linkages to the healthcare system, the people in the healthcare system. We become partners and we train them on two things. One is how to identify and care for mental health problems. And secondly, how to reduce within themselves burnout. Because our colleagues all over the world working in resource-poor environments with highly traumatized populations have a massive burnout. Self-care has to be top priority, like in Ukraine. The self-care of the teachers in the school system, the teachers and the parents has to be top priority. Because they're getting wiped out by the vicarious trauma, you know. So we build the partnership in a resource-poor environment, scarcity environment. The other thing we have to understand is the scarcity model all over the world, including rich countries, is rampant. The scarcity model means we don't have enough for everybody. And and if you win, I lose. Very competitive. We live in very competitive societies. And we have the generosity model, which is opposite. My mother taught me this. We're Italian immigrants, and she said, see this spaghetti pot? It can feed one, but I'm not going to eat. One Italian doesn't make spaghetti for themselves. I'm going to feed 20 out of the spaghetti pot. I can feed a whole community out of the spaghetti pot on practically no money. In other words, everybody has something to offer somebody else, including children and teenagers, and including animals and plants. I want to throw that out there. You know, we got to engage. Everybody can chip in to help everybody. That's the generosity model. That's the Italian pasta model. You know, I don't believe in the scarcity model. I think the scarcity model doesn't work. It doesn't work. We need a generosity model in healthcare and in caring for people who've been traumatized.
Thank you very much, Professor Molika, for these very warm and heart-touching words, and also encouraging us not to think of the problems but about the solution, and we definitely should be much more generous. So thank you very much for waking up so early in the morning and connecting with us. You had a wonderful audience, more than 100 people was listening to you. So thank you very much for accepting our invitation. So goodbye.
No, thank you for this honor.
Thank you, Richard. Thank you so much. I love the pasta model. So thank you, and relax a little bit, and we keep in touch. Thank you again for this wonderful lecture.
Well, thank you. I'm honored. It's an honor for me to be here. Thank you so much.
Thank you. So now I invite Professor Jutta Linder, our next speaker. She will speak about generational impact of trauma. Professor Jutta is a full professor of public health at the University of Applied Sciences Emden-Leer and visiting scholar at the Women Research Center in Brandeis University Waltham and at the United States. And as I mentioned before, Professor Jutta is also president of Mental Public Health Section in UFA and also principal investigator of EARLY project that we are part of. Jutta, the floor is yours.
Thank you very much, dear Lukas. Unfortunately, I'm not anymore at Brandeis because the term was over, so only to be correct. It is very difficult to continue with the talk after Richard. I knew it would be difficult, but I didn't know that it would be so difficult. Because now I'm going to share with you about some data and some knowledge, and I think maybe we should all only briefly stand up, breathe deeply, and then we can listen to the facts. So maybe stand up if you want. Just 1, 2, 3 deep breaths. Okay, now we are prepared for transgenerational trauma. Please have a seat again. Transgenerational trauma, it is really an honor and a pleasure, and I'm very humbled to speak here in Poland about transgenerational trauma. Transgenerational trauma is increasingly something we are thinking about. What does history do to mental health? It is timely as May was Traumatic Stress Awareness Month. The aim of the Traumatic Stress Awareness Month was to raise awareness for those affected by trauma, and by promoting awareness and extending support, hopefully we can create a world where the effects of trauma are met with empathy, understanding, and potentially healing. However, there are reports and studies which suggest that psychological trauma is passed down from one generation to the next. Therefore, in this talk, I will show and share with you some knowledge we have about the transgenerational impact of trauma. The topic of transgenerational impact, of course, is particularly poignant for Central and Eastern European countries. This region mainly consists of countries that endured decades of political oppression under the totalitarian rule of the communist regimes, as well as dependency on the Soviet Union during the later half of the 20th centuries. These countries in this part of the world are currently facing multiple layers of traumatic experiences and challenging transitions. The most recent being the Russian war of aggression on Ukraine. This war, of course, addresses an earlier layer of historical traumas in the region, namely the trauma of the Nazi occupation and the trauma of the Soviet communism. However, research on the long-term mental health consequences of trauma remains somewhat limited in this part of the world, which has been named Bloodlands. Bloodlands is a term coined by Timothy Snyder that describes the countries in the eastern part and in the central part of Europe, including Poland. In the mid-2000s, a researcher, Brent Benzer, and his wife were living in Ukraine when Benzer began noticing a kind of behavior common in the population. In his conversation with people, Benzer heard references to the Holodomor, to the mass starvation of millions of Ukrainians from 1932 to 1933. Wondering if and how this continued, he started his research. And this was an important step to better understand the impact of violence from an historical perspective. A study by researchers from Warsaw University suggests that around 19% of Poles, almost 1 in 5, have symptoms of post-traumatic stress. So very, very high. The numbers are much higher than in many other countries. And these numbers raise questions about the potential causes. We all know that Poland was occupied by both Germany and the Soviet Union. Nazi Germany pursued a policy of extermination towards Poles, including attempts to destroy Polish national identity, cultural destruction, mass displacement, forced labor deportations, and obligatory services in the German military forces. We know that these Nazi crimes resulted in a killing of 6 million Poles, including 3 million Polish Jews, which is the highest percentage of deaths in all countries involved in the war. But it did not stop after the Second World War. Under the Soviet occupation, again Polish citizens were deported or killed, with the aim of depolonizing the new territory. So, what does it make with a country, with a people, such kind of history? The evidence for intergenerational effects of trauma, however, remains contradictory. Some studies confirm the existence, others do not. And the results always also depend on the sample and on the methods, on the research methods used. And the colloquial quotes we know are contradictory as well. We know the quote, at least in German, time heals all wounds. The past is past. But then there is this famous quote from William Faulkner. In one of his books, he writes, "The time is not past and will never pass." So what do we know about the impact of traumatic stress, of trauma, on offspring? It has been more than half a century since Vivian Rakoff observed the problem of intergenerational trauma among descendants of Holocaust survivors who did not experience the Holocaust directly, but were affected by parental traumatic history. And in the following years, after Rakoff's groundbreaking research, still there are questions. And there is a debate whether the offspring of survivors suffer indeed from psychopathology or whether psychopathology is restricted to a small, non-representative portion of offspring of survivors. In other words, the question is a debate about the effects of traumatic events. The question is whether the effects can be neglected once lifetime rates of abuse are accounted for, and this is something we spoke about during the panel discussion, whether the ongoing exposures count. The other opinion is that powerful, stressful environmental conditions, such as mass violence, can leave indeed a mark on the epigenome, on the cellular material that can be carried on into future generations with devastating consequences. The second hypothesis includes that traumatic events can lead to biological changes, and such information as parental trauma may be inherited transgenerationally at different levels, at behavioral, neuroanatomical, and epigenetic levels. Yet, most people do not show symptoms. And there is always an overlap of resilience and trauma. after experience or during experiencing traumatic events, the world can collapse. The view of the world can collapse. And the defense mechanisms do not work anymore, leaving people unprotected. Yet, people are not unprotected in total, but still there is resilience. And always, if people are exposed, both reactions are happening. Resilient reactions and trauma reactions. So I will summarize the knowledge in the talk on the impact of traumatic events on survivors' offspring. I will analyze some commonalities and differences, and finally identify vulnerability and resilience mechanism. First of all, what are traumatic events? And how frequent are those events? Basically, traumatic events are those which overwhelm the ordinary systems of care that give people a sense of control, a sense of connection and meaning. They are deeply distressing and disturbing, and they involve a fear and threat. This may include exposure to death or to threatened death, or to injuries or threatened injuries. We spoke about different types of traumatic events. These events might be individual events, like child abuse, family violence. So, on an individual level, there are enough events which might affect people. Additionally, to the individual level, there might be collective levels of violence, and the collective levels are basically war, conflicts, including discrimination and racism. So, what is historical trauma? Historical trauma basically is related to the historical events. In Eastern Europe, until Stalin's death in 1953, around 8.2 million people were directly killed. 7.5 million people were deported, and 5 million were put in prisons. Approximately 1 in 8 adults is estimated to have been a victim of some form of repression, meaning that indeed there were victims almost in every other family during this phase. So, what can be done with the experience of historical events? Historical trauma theory states that these events, these stressful and traumatic events, are not only individual experiences, but also collective ones that impair identities, social structures, and the way of life within affected communities. A defining feature of this specific trauma exposure is its cumulative nature, meaning that injuries accumulate over time and are typically inflicted by a dominant group into a more vulnerable one. So, historical trauma is something to be thought about, which adds to our knowledge of individual trauma. Both types of trauma, the individual one and the historical one, can be intergenerational or transgenerational. Intergenerational trauma refers to the specific experience of trauma across familial generations, which means such events like domestic violence is shared across generations. Transgenerational trauma and transgenerational transmission of trauma is defined as a transmission of the effect of an experience of trauma from a group or an individual to one generation or to later generations. Transgenerational trauma, therefore, encompasses both the direct intergenerational transmission as well as generation skipping, transgenerational transmission. Historical trauma in this context of transgenerational transmission therefore is experienced over time and across generations by a group of people who share an identity, an affiliation, or share the circumstances. Historical trauma was originally introduced to describe the experience of children of Holocaust survivors. And in the past 2 decades, it has been applied to numerous groups throughout the world that share a history, a common history of oppression, victimization, or massive group trauma exposure. Scholars, researchers from various disciplines have described these generational aspects of historical trauma in an intergenerational and transgenerational way. Which means, if we take this together, looking at the different definitions of intergenerational, transgenerational trauma, individual and collective trauma, we can ask ourselves what matters. What matters in all those exposures? And finally, we see that what matters is betrayal and belonging. So the traumatic experience is basically a relational experience. And the trauma is a relationship trauma. Now we can ask ourselves, how frequent are these traumatic events? And this is one of the numbers we estimate, but probably there are other numbers more accurate, because at the moment we do not have the real numbers, and the numbers are changing, of course, all the time. At the moment, we think that 70% of the world's population has been exposed to any type of trauma. Might it be childhood trauma, might it be gender-based violence, or might it be armed conflicts? For armed conflicts and war stress, we know that this type of traumatic exposure has an endless number of varying configurations. From the stressful exposure to war, news on the media, or to losing dear ones, to destruction, forced relocation, shortage of food, exposures to cruelty, death, and shattered lives. Which means that the traumatic experience is related to relational trauma and as well to uncertainty and unpredictability. Uncertainty about what goes on and where to go in the future, unpredictability regarding one's near and long-term existence. And for the war in Ukraine, we only begin to understand the extent of the impact this war has on the Ukraine itself and on the neighboring countries. So, what are the potential effects of traumatic events? Before we can answer this question, it might be necessary to define what is meant by mental health, social health, brain health, and resilience. Mental health might be the easiest one. mental health is conceptualized as the capacity of thought, emotion, and behavior that enables people to realize their own potential. Another feature of health, sometimes neglected, is social health. Social health is the ability to interact with others and the ability to perform meaningful relationships with other people and interact in positive ways, not in negative ways. Additionally, we know that brain health is affected by traumatic experiences, and Richard Molliker already introduced it a little bit to the changes in the brain. We know that the brain basically is a social organ, and because it is a social organ, it is reacting to all experiences which people are encountering, and traumatic experiences might be related to executive functioning, to episodic memory, and as well to early cognitive decline, because there might be changes in the brain. We spoke a lot additionally about resilience. Resilience often is connected to the topic of trauma. And there is one interesting study from Lithuania showing that those who were oppressed during the communist regime and the families who suffered directly showed more symptoms of resilience compared to those who were not directly oppressed. So what is resilience? Resilience has many, many definitions, and basically it is the ability to overcome adversity and experience positive outcomes. Some time ago, it was conceptualized as a linear model. Nowadays, however, we understand resilience more as a multidimensional outcome, which is constituted by internal resilience, so by the sources of resilience within the individual, by coping mechanisms, so by skills, and by external resilience. So resilience never is something which is only internally, but external resilience is crucial, like the socio-ecological factors that promote resilience, such as the access to services. Taken together, nowadays, resilience can be defined as the ability to identify and use individual and collective trends and to thrive while managing the risks. As well, Richard Molliker spoke about hope. So hope is one of the crucial features of resilience, because wherever we are faced by traumatic events, immediately there is a reaction to try to help others around you. Thus, although each of us has the seeds of resilience inside, these seeds need to be cultivated, protected, and assisted by the actions, by decisions, and these decisions and hope might influence health. So if we are thinking about the impact of traumatic events, we should always think about the different layers of health. Now let us dig a little bit deeper, I will make it short, into the transgenerational impact of trauma. At the beginning, after World War II, there were some autobiographical reports, case studies, and some scattered clinical studies. The dominant type were autobiographical reports. And maybe let me share a case from someone from Georgia, a story because it started with storytelling. As an 85-year-old woman living in the Republic of Georgia reports a happy childhood. However, when she was a teenager, persecution measures began against her parents and her older brothers. She witnessed their multiple imprisonments and then had to take care of the younger children. Her father and brother disappeared completely, and she believed they had been killed. She and her siblings were labeled enemies of the people. She was forbidden by the authorities to talk about her experiences, which she kept to herself for 50 years. Since 50 years, she has strong fears, is easily frightened, and has repeated nightmares. Even nowadays, she is afraid when a car stops before her window, and she can no longer fall asleep. Because of her many fears, she lived a very secluded life and brought up her children that way. She continues to feel the effects of the experiences of her family member until today. So this is an autobiographical report, and while preparing the lecture, I checked what has been published in ISI Web of Science. There is not much, but at least it is increasing with almost 219 studies now reporting some kinds of impact of historical trauma. The effects which studies suggest have an effect at various levels, such as at the cellular level, the health level, especially on the brain, we already spoke about it, but as well on community, on societies. So how communities are behaving and people in the societies. A number of these studies suggest that groups who have histories of historical trauma are more vulnerable than others. So, yet, these effects can be identified as mental health effects. Clinicians began to report, and these studies show, that second-generation offspring and third-generation offspring sometimes presented more psychopathology linked to their parents' and grandparents' experiences. And finally, there were quite a few studies which investigated more effects than only the psychopathological effects. One effect which might be particularly interesting is decreased interest in the future, so no interest to perform, no interest to achieve anything. Another impact was the feeling of humiliation and behavioral difficulties. I will speak about it in a minute. Which means that exposure to this kind of transgenerational historical violence may not only be associated with psychopathology, but as well with some kind of behavioral changes. One way of assessing these changes is by investigating adaptional styles of children. And for a long time, there wasn't any measure to measure these changes until Yael Danieli, who is one of the groundbreaking researchers in the field, developed a measure to assess the multi-generational effects of trauma. And this measure was used in the Polish version of the Danieli Inventory of Multi-Generational Legacies of Trauma, Survivors Post-Trauma Adaptional Styles. This tool was used in a study in Poland. It consists of 60 items describing specific emotions, beliefs, or behaviors. There are 3 adaptational styles: victim, number, and she called it Jael, or we called it fighter style. And it was found in this study from Poland that indeed there are impacts on the adaptational style among the offspring of survivors, moderated by knowledge about the historical events. The survey was conducted between September and October 2022 by an external company, and we see the name of the researchers. The participants represented different generations of Poles before, during, and after World War II. The study observed a positive relationship between all survivors' post-trauma adaptational styles and current levels of PTSD symptoms. So the question is, can we trust these numbers? And to try to answer this question, I did, together with the colleagues, a meta-analysis trying to bring together all the knowledge what we have. We found that indeed there are some studies suggesting that there is a difference between those who have been exposed compared to those who have not been exposed. So there is some empirical material which is related to the numbers that we have, and the numbers tell us a story not only about mental health effects, but as well about social health effects. And here I would like to share with you some results. I know it's difficult to read about the social health effects. Social health effects in Ukraine, that the messages of the parents were transmitted to the children, such sentences like, "Do not show your fears," and "Do not trust," which means indeed that is not only an individual behavior, but that changes in society might be related to the exposures. What are the models? I'm running out of time, so I will make it very short, because I think biological mechanisms already have been mentioned by Richard Mollica. A large body of research suggests such a biological embedding. A biological embedding refers to the biological mechanisms by which adverse experiences get under the skin. The primary organ where these experiences get under the skin is the human brain. Mainly involved here is the prefrontal cortex, which is associated with decision-making and working memory. The brain is plastic throughout the life, which means that not only bad experiences are rewiring the brain, but as well positive and good experiences. Synapses and neurons, whole brain regions, accordingly change as a function of experiences. This plasticity, of course, is particularly pronounced early in life. Nevertheless, the brain is plastic throughout the whole life course. So, negative experiences can create changes, but as well, positive experiences can rewire what has happened. Therefore, it is important to remember that the transgenerational impact happens in context. And if the context is a promoting context, then as well the deeply embedded changes can be rechanged again. So the question is, what matters? And it matters at the end of the day a public health model, which overcomes the individual pathology model. The effects of the exposures are multi-level and include individual, relationship, community, and society. One example might be parent-child interactions. As the impact is multidimensional, good interactions at the parental level, at the individual level, might help, might be proactive, and might increase resilience of those affected by further exposures, which can contribute to a preparedness model within the public health framework. Prevention of traumatic experiences, of course, is the most effective intervention approach, but sometimes it's not possible. Then we have other possibilities to strengthen relationships and to build strong, resilient skills within this framework which goes beyond the individual person. And because at the end it matters beyond the preparedness, it matters, what matters is justice. Justice includes collective memory, and collective memory includes the ability to face the history, to face what has happened, what can be transmitted in narratives or even in changes in the law. And working towards belonging within families, belonging within communities, to counteract the effects of betrayal, of the relational trauma. Taken together, a public health framework for traumatic stress is critical for understanding the risk and protective factors of transgenerational trauma, and the mental health is related to one's ability to process the narratives of the past and to form attachment bonds and trust in spite of the events which happened. We know that exposure to trauma is pervasive in societies worldwide. And population, these data show us that the majority of adults are experiencing a traumatic event, despite, of course, the cross-national variation in the prevalence. But even if it's pervasive, there is a possibility to strengthen the community strengths which can help to identify the pre-trauma situations like the situation we are facing now. So with this, very quickly, thank you very much for having this opportunity to speak about transgenerational trauma here at this historical place.
Thank you very much, Jutta. It was wonderful, informative presentation, especially as you mentioned, in a place like this. Gdańsk has a huge history. Yeah, so thank you very much for being brave and speaking about such a traumatic events from our past. So I admire. So now, unfortunately, we are run of time. So if you have any questions to Jutta, please catch her up at the lunch. We have now a 45 minutes break, so we are meeting here 5 to 3 because in the last session we will have presentations from Red Cross, from Professor Shalimova, and wonderful conversation with our panelists. So, lunch break. final session that consists of 2 short lectures and a panel discussion on trauma in the experience of medical professionals. So now I would like to invite Agata Gajos, who is an active humanitarian worker associated with the Polish Red Cross and especially working in Pomerania region, to share her experience. Thank you.
Hello, welcome. We're not waiting, okay. So you will be chosen one, because I know it's not appropriative, but you can stretch now for just for a second, and we have 20 seconds left, I hope. Can we stand up for a second? I know you, after the lunch, it's the best and the worst time to speaking. You're the next chosen one. And I know our spinal fluid is something like down here, and I want to here, so we get stretching down. Okay, like this. Okay, this chosen one, you can sit. Thank you. I hope we have 15 minutes. You're not going to sleep, and I want to tell you something about, you know, the Red Cross. I hope. Can I? Oh. I have it here, but I don't have glasses. I'll tell you a few words about the mission of the Red Cross. I hope you know this organization. It's the biggest organization in the world, almost in every country. So we try to be inspired for the smaller organization, for the local governments, for anybody who wants to pick something from us. And what we prefer is to prepare before the crisis. So we are still have trainings, our rescue teams, our humanitarian aids, and I'll tell you later about it. It's about the 3 pillars. We believe that healthy and self-aware society, it's better prepared to deal with crisis, because this will happen, and we can be sure about it. I'm not talking only about war and big traumas, big crises, but also a flood last year in Poland. So when we have societies self-aware, we can provide our help in a better way. What Red Cross, okay, is doing the best. I think we here in a group of people who know, like no one else, that mental health matters. And why? Why? Not in a very medical way, but I think about society. I want to show you this pyramid, but I will back to this. Now I'm tell you a few stories about the basic psychology support. This role of MHPSS in a crisis situation is not just a slogan. It was helping in a few crises. We took part of it, and I tell you briefly, very briefly, what it's all about, and I'm back to this pyramid. This basic psychological support, it can be immediate. Emotional support in a place we are in this situation. No matter war, flood, another disaster. It's designed to be very simple, and anybody can give this emotional support. Of course, I have colleagues in my group who are, I hope, well trained, but okay, I can dig a hole, I can carry the food, I can carry the water, but don't ask me to talk to them. Don't ask me to look at their eyes, because you know, when you're in a crisis situation where is a panic, where is people are crying, it's not a situation like this when we're talking about trauma, we're talking about attacks. The very, very hard, big men rescuers are having very, very big problems to deal with it. And of course, there's data, I don't have to tell you this, that early psychological support is preventing from serious mental problems like post-traumatic stress disorder and anxieties and also depression for a long time. What's next? What is important when the people losing controls, losing their lives, losing everything they had before? The sense of safety and control. The control that they can bring the water to the older people in the same situation. We always ask for help. People, we provide this help and food, everything it's humanitarian aid, but giving them sense of safety and control is the most thing we should do in this moment. I hope, because every humanitarian aid, everybody knows what is this, but for me, it should be a holistic humanitarian response. It has to have a psychological support. It's not only a food, it's not only medical stuff, it's not only shelter. Of course, it should be the first, but not only this. And I go back for a moment for this, because you know, as you can see, we have a few points here. Psychological support, psychological support, special mental care. And I can tell you a brief story about the flood last year. You know, the people in South are used to the floods because it happens every 10, 15 years. But we were sent to the place with a very big damage because of the broken dam. It wasn't look like just a flood. It wasn't victims. They didn't need a warm meal. They need everything. They need shoes. They need anything. They lose homes. The buildings are not existed. When we came there, I have big, strong guys in my teams. There are firefighters, there are rescuers, there are lifeguards. They're very well trained. But when we came there was a totally silence. Silent. And this. They will look at this and, wow, what can we do? Because there was no people to rescue in that very moment. They were alive, mostly even, thanks God. But we have to deal with their emotions, with the chaos, panic, with things you don't have to deal with it when you have to rescue one people from the, I don't know, fire or maybe on the sea. The leader of the rescuers told me that he never thought that they will follow my order. And I asked them to just talk to them, be with them. Okay, bring the food, bring the clothes. But the most important was just to be with them before the system will, because, you know, that wasn't war. That wasn't the worst thing could happen. We knew that the system will work. In a week, in 2 weeks, the army will come, they will survive. But this time we try to be in a place as short as we can, because it's the next thing to give the control to the society, because they can better work when they feel that they have a control again. And what's next? Very okay. And next situation we have, because that was a natural disaster, and now and from few years we have a problem with war trauma. And the first point, 5 of 6 teachers feel that they are not trained to work with children who have war trauma. And of course they're not, because we didn't tell them they have to do. Before the war, before a pandemic period, there was a problem, and there was a psychologist in the school, and they have to deal with it. Of course, it wasn't perfect, but it worked. Now they have almost 70% children with some kind of problems. So we prepare something we call psychological first aid. It's based like a medical first aid, that anybody can provide this. Anybody can do this. Of course, I hope we have skill. Not skills, we don't need a very special skills, we just have to be a person who not walking away, who's just looking what is happening. And the next program, Sport Coach Plus, it's just for teachers and coaches for sports, just not to leave these kids alone, to can see. And Professor Richard said one important, very important things, and a wonderful lecture, but he told, I write it down, LUDA, listening, understanding, and deep appreciation. And we have a very similar focus. It's about look, listen, and connect. We don't have to be a specialist, as you are, but all the people you work with, you know, can use psychological first aid and help to start the way to recover. I know it's here. The foundations of MHPSS, it's of course with the people who had a trauma, with the displaced people, but also our volunteers, because Red Cross, it's based on thousands of volunteers in all over the world, and in Poland, of course. So we have to care about them, and we'll talk about it later, I think, because our staff, we are meeting once a year with the whole group. It's a massive training, but I don't know each of them, but I have to know that they are well prepared, and we are caring about them, because is a good rescuer, good helper, is a living helper, that he can be strong. We can make cooperations with the NGOs, with the local governments. Is all we do. I can see the time, so I go there. What we can do next? I have to go to the end, yes? Okay, so 2 minutes. What we can do, we have a few programs in all over the Poland, I can speak about Poland, but I know it's in the world, it's also. We can make a bigger scale. We can build the partnerships to show this, not only on these conferences, just on the people who live very, very far away from the cities. And we can inspire a little NGOs that working there, what is very, I want to show you a 1-minute film because I didn't have a time to talk about all the programs, but it's about our beneficiary, and it's, I'd like to share this history because it's hundreds of them. Can I have this film already? Okay. Okay. You know, they lose everything. They lose country, home, almost lives, and it happens like this, what we will see, I hope. Just 1 minute.
На початку війни була дуже небезпека ракетних ударів і захоплення всього міста. Тому мені було дуже страшно, і тому було таке рішення виїхати з дітьми в безпечне місце. Я юристом, тут мій фах не був затребуваний, мусила навчитися чомусь новому, перепрофілюватися, коли вивчила польську мову. Я записалася на ці курси масажу, які мені оплатив Червоний Хрест. І завдяки цьому я на даний час знайшла роботу, працюю в масажному салоні «Масаж Лайн» в Гданську.
Приехала разом с сыном с Украины, с Херсона, там, где была, в той час была оккупация еще. Я мала добре життя. Я працювала 10 лет як вулична мова. Я скончила курс помощи людям з старшим особам. Ну, я мала не тільки старших особ.
Okay, there was one more. I've heard that she has a good life, and I hope it will will be like this, and will be in a, this future when we can. Professor Richard told about that we can go out with this trauma, and I hope we can put just one part of it, and we can share with our programs if you'd like to. Thank you.
Thank you very much for the presentation and the video. And now I invite Professor Anna Szalimova, who is a professor in our university, but also a full professor at Kharkiv National Medical University in Ukraine. So please, the floor is yours.
Okay. Dear colleagues, it's my great pleasure to present part of result of our international project in which we study the association of void use stress and hypertension in Ukrainian refugee women. Why this topic? Because 1 in 5 people who have experienced void during previous 10 years may, according to World Health Organization, may have depression, anxiety, mental stress disorders, other mental stress disorders, and in applying this estimate to Ukrainians, approximately 10 million of Ukrainians may have mental stress disorders. What do we know now about the association of post-traumatic stress disorders and hypertension? First of all, post-traumatic stress disorders and its association with hypertension was studied among military servants, war veterans, and in population exposed to chronic violence. It is known that refugees have particularly high prevalence of post-traumatic stress disorders, according to different data from 20 to 60%. However, to our knowledge, the association between post-traumatic stress disorders and hypertension has not been previously investigated. From the end of 2022, in our Medical University of Gdańsk, we start the project in which we investigate the effect of war-induced stress on the development and progression of hypertension and cardiovascular disease in Ukrainian refugee women in Poland. This project is financed from Polish National Science Center. And in our project, we test the hypothesis that psychological stress and trauma exposure may increase blood pressure and contribute to hypertension worsening development and also to progression of cardiovascular disease. And the second hypothesis, that the integrated management of subject with stress inclusion psychological approach can be potentially decrease cardiovascular risk in refugees. And we hope that result of our project will pave the way to a specific approach of cardiovascular risk management in subjects exposed to chronic violence, war, refugees, and migrants. And this is the first result of our project in which we involved 55 Ukrainian refugee women who were housed in the dormitories in Sopot. The aim of this part of the study was to know is PTSD is more frequent in a hypertensive subject. We confirmed the presence of hypertension according to office blood pressure measurement and information about antihypertensive treatment. Women filled validated questionnaires for stress assessment, questionnaires DAS, Depression, Anxiety, Stress Score, for assessment of emotional distress, and questionnaires PTSD, for assessment of PTSD, questionnaires PCL5. And we had two groups of women, hypertensive women and normotensive women. It should be known that these women had no differences in pre-flight status. Therefore, these women had no differences in educational level, socioeconomical status levels, with the severity of the fighting in those regions from which these women arrived to Poland. However, a perception of safety in Poland was different between hypertensive and normotensive subjects. Significantly less hypertensive women identified that they felt completely safety. When we compare the data of emotional distress between hypertensive and normotensive subjects, we had no statistical differences between these two groups. However, the data of post-traumatic stress disorders, PTSD score, was significantly higher in hypertensive subjects, and also such clusters of PTSD as increased arousal and reactivity and re-experienced trauma intrusion symptoms also were significantly higher in hypertensive subjects. The first result of our studies we published in the leading journal of hypertension, and our conclusion that the prevalence of PTSD in refugees was 7-fold higher than in Ukrainian women before war. And PTSD in hypertensive Ukrainian refugees was 9-fold higher than in normotensive subject. The next result of our project we presented in the International Society meeting in Colombia last year, and the aim of this part of the study was to investigate the potential association between stress disorders and hypertension among Ukrainian refugees. And in this part of our study we included 504 Ukrainian refugee women. It should be noted that in groups of hypertensive and normotensive subjects, we found the significant differences not only in PTSD and also in the severity of emotional distress. DAS score and all the and such parameters of emotional distress as depression, anxiety, and stress also were significantly higher in refugee women with hypertension. And PTSD score and all the clusters of PTSD also were significantly higher in hypertensive women. Logistic regression analysis revealed a significant association with hypertension and one of the cluster of post-traumatic stress disorders, persistent recurrence of traumatic thoughts. Therefore, according to this part of study, we can conclude that hypertensive refugee women had significantly higher prevalence of emotional distress and post-traumatic stress disorders, and among all the studies, indicators of stress, re-experienced trauma were the indicators that most strongly associated with hypertension. And when I worked in Colombia, I received an invitation for popularization of our study in the main digest of the International Society of Hypertension. And at the end of last year, information of our project was published in this digest, Hypertension News. And now, a few words about new results of our project, which I presented last week in the European Society Hypertension meeting in Milan. In this part of our project, we compare the data of severity of hypertension and emotional distress and PTSD among Ukrainian refugees in Poland and Ukrainian women remaining in Ukraine. Thanks to association with 3 medical centers in Ukraine from my native city, Kharkiv, in Kyiv and Ivano-Frankivsk, we received the information about blood pressure levels, severity of hypertension, and severity of stress in Ukrainian women remaining in Ukraine. In this part of our study, we include 173 Ukrainian refugee women in Poland, in Tri-City, and 161 Ukrainian women remaining in Ukraine. And interestingly is that women remaining in Ukraine were significantly older and they had higher prevalence of hypertension. However, the control of blood pressure was significantly worse in refugees. Only 5% of refugees had good control of hypertension in antihypertensive drugs. Perception of safety also was different between refugees in Poland and women remaining in Ukraine. Significantly more refugee women indicated that they felt themselves totally safety. However, despite the high perception of the safety among refugees, the severity of emotional distress and such a component as depression and anxiety were significantly higher in group of refugees. Furthermore, a severity of post-traumatic stress disorders and all the clusters of post-traumatic stress disorders also were significantly higher in group of refugees as compared to women remaining in Ukraine. Notably, that 74% of refugees indicated the war as most stressful factor in their life, and 48 women remaining in Ukraine indicated the war as the most stressful factors in their life. Therefore, we can conclude that refugees have more severe emotional distress, such as component as depression and anxiety and PTSD, as compared to Ukrainian women remaining in Ukraine. And it could be due to the challenges due to the forced migration, yes, such as limited access to medical care, to employment, social isolation, language barrier. And alternatively, refugees may carry this higher burden of previous exposure of violence, required target medical and mental health follow-up. And at the end of my presentation, I would like to thank to all our international team from 4 countries, Poland, Belgium, Switzerland, and Ukraine. This is the link for our project. And I would like to say that last week we received a great news that we will continue our project. We have a new grant from the European Union, and therefore we can prescribe follow-up for those refugees who previously were recruited in the project. And apart from detailed assessment of cardiovascular disease, we also can prescribe assessment of cerebrovascular disease. Thank you very much for your attention.
Thank you very much, Professor Shalimova. I think the message that I got from this presentation that when trauma happens, the whole person suffers, not only the mental health, but also physical health. So thank you very much for this part. And now we are smoothly going to the panel discussion that will be moderated by Dr. Olga Kalinowska-Beszczyńska. It's a good connection from that we have to talk about the trauma caused by war, but we also have a more sometimes more closely traumatized personnel, like medical personnel. So that's why I invite Olga, and Olga, the floor is yours.
O, dzień dobry Państwu.
Oh, just an information, this panel will be in Polish, so mówimy po polsku.
Tak, słychać mnie czy nie słychać? Dobrze, to w takim razie. Jeszcze raz, ten mikrofon działa, także dzień dobry Państwu. Witam serdecznie na naszej dyskusji panelowej. Także ostatnich kilka chwil poświęcimy dyskusji na temat traumy w doświadczeniu zawodów medycznych. Także popatrzymy troszkę z innej strony na ten sam problem. I chciałabym bardzo serdecznie zaprosić panią profesor Annę Szalimową do nas, panią Agatę Gajos, żeby do nas dołączyła, jak również panią Jolantę Zboińską i pana Karola Bączkowskiego. Czy jesteśmy wszyscy? Mikrofony powinny za chwileczkę działać. Udało się? O, także panią profesor już mieliśmy tutaj okazję wysłuchać, także dziękuję bardzo. Panią Agatę Gajos. Również pani Jolanta Zboińska jest psychologiem, psychoterapeutą, również prezesem Fundacji Pomorskie Centrum Psychotraumatologii, przepraszam. Oraz jest z nami również pan Karol Bączkowski, który jest ratownikiem medycznym z wieloletnim doświadczeniem, również edukatorem w zakresie pierwszej pomocy. Także jeszcze raz dziękuję Państwu za przybycie i udział w naszej dyskusji i chciałabym może zacząć od takich bardziej osobistych refleksji. Do pani profesor pytanie trudne. Czy osobiste historie lekarza stanowią bardziej zasób terapeutyczny, czy raczej zagrożenie dla własnego zdrowia psychicznego w pracy z pacjentem?
Szanowna Pani, bardzo dziękuję za pytanie. Naprawdę jest trudne i ciekawe pytanie, no, ponieważ jak mi się wydaje, że nie ma takiej jednoznacznej odpowiedzi na to pytanie. I no, ponieważ my jako lekarze jesteśmy tymi samymi ludźmi, co i pacjenci, których leczymy. I każdy z nas ma własne doświadczenia, emocje, jakieś przeżycia dnia codziennego, które naprawdę tak no, nie mogą nie wpływać na naszą pracę, na komunikację z pacjentem. I każdego dnia lekarze, nie tylko lekarze, ale inne pracownicy medyczne są narażeni na różne czynniki stresowe, które mogą wpłynąć i na stan fizyczny, i na samopoczucie, na komfort emocjonalny i w końcu doprowadzić do wypalenia emocjonalnego. I dlaczego tak się dzieje? No ponieważ codziennie kontaktujemy z ludźmi w trudnych sytuacjach życiowych. Potrzebujemy bardzo często natychmiast podejmować jakieś decyzje. analizujemy duży obszar informacji. Potrzebujemy jakoś nawiązać dość dobry kontakt jako z pacjentami, tak i z ich krewnymi. I dlatego na przykład według wielu badań od 30 do 90% lekarzy są narażeni na wypalenie emocjonalne. I te wypalenie emocjonalne nie może dotykać tylko lekarzy, tak? To ono wpływa i na pracę całego zespołu i na komunikację, leczenie pacjentów. I oprócz wypalenia emocjonalnego chciałabym jeszcze poruszyć taki jeden temat, który uważam, że w obecnych realiach bardzo się wpływa na komunikację, na interakcję lekarz-pacjent. I tu w tym aspekcie chciałabym powiedzieć o warunkach pracy moich kolegów lekarzy w Ukrainie. Tak naprawdę, że trudno sobie wyobrazić, jak te czynniki zewnętrzne mogą wpływać na wykonanie przez lekarzy ich obowiązków profesjonalnych, ponieważ z jednej strony lekarze non-stop udzielają pomocy medycznej pacjentom, ale z drugiej strony oni przede wszystkim są ludźmi, którzy boją się za swoje życie, za życie i zdrowie swoich bliskich. Oni są ludźmi, którzy nie mają pewności w jakiejkolwiek przewidywanej przyszłości. I to naprawdę nie może, to ich własne doświadczenie, nie może nie wpływać na leczenie pacjentów, na ich komunikację z pacjentów. Tak naprawdę byłam przerażona, kiedy zobaczyłam wyniki badania przeprowadzonego w Ukrainie wśród 200 psychiatrów, którzy pracują w Ukrainie podczas wojny. Chyba wśród tej kategorii lekarzy, którzy jak najbardziej wiedzą, jak sobie radzić się z emocjami. I co się okazało, że wśród 200 psychiatrów prawie połowa miała umiarkowany stopień wypalenia emocjonalnego i dezadaptacji zawodowej, a 1/5 już miała bardzo zaawansowany stopień tych zaburzeń, który potrzebował zewnętrznej interwencji. I to naprawdę przerażające liczby. I podsumowując, tak moja odpowiedź na to pytanie, chciałabym powiedzieć, że interakcja lekarz-pacjent to jest zawsze wzajemna. I stan emocjonalny, zarówno jak i stan fizyczny obu stron jest bardzo w tym ważny. Dziękuję bardzo.
Dziękuję bardzo. To może kontynuując to pytanie do pani Zboickiej, w takim razie jak pani widzi, jakie działania profilaktyczne i edukacyjne, tam powinien być, przepraszam, jakie działania profilaktyczne i edukacyjne powinny być priorytetem dla organizacji, które zajmują się obszarem zdrowia psychicznego w tym właśnie kontekście, generalnie świadomości dotyczącej traumy, co powinniśmy zrobić w pierwszej kolejności?
Przede wszystkim dziękuję za zaproszenie do tego wydarzenia. Ja może zacznę kilka jeszcze zdań na temat samej traumy, bo na przełomie XIX i XX wieku słynny psychiatra Sándor Ferenczi, węgierski, powiedział: trauma jest nie do przecenienia jako czynnik wywołujący chorobę. I właściwie nie podważono tego do dzisiaj. Dzisiaj jesteśmy dalej w rozumieniu, myśleniu oraz w sposobach pomocy. Natomiast ja myślę, że w naszym społeczeństwie, myślę tu o Polsce, ciągle jeszcze w niektórych gremiach pokutuje takie przekonanie, że pacjent kończy się na skórze. Ale rozwijając tę myśl, należałoby powiedzieć, że ani pacjent nie kończy się na skórze, ani medyk nie kończy się na skórze, ani też przedstawiciele służb pomocowych nie kończą się na skórze. A więc wszyscy mamy tę odpowiedź emocjonalną, która z jednej strony jest niezbędna do tego, aby być zdrowymi psychicznie i żywymi psychicznie, ale stanowi jedno z największych wyzwań. To znaczy, jednym z największych wyzwań ludzkości jest konieczność radzenia sobie z emocjami. I to jest obszar, myślę, do zaopiekowania z jednej strony w taki sposób, aby nie pomijać tej strony psychicznej, aby mieć ją na uwadze i wspierać. I bolączką jest to, czy taką właściwie z jednej strony powszechną wiedzą, ale też i niepowszechną jest fakt, że zaburzeń psychicznych nie widać. Prawda? I mamy też w psychotraumatologii takie pojęcie jak trauma ukryta, cicha trauma, prawda? I myślę, że my możemy to pomijać i jak gdyby myśląc o medykach i myśląc o pacjentach, możemy jak gdyby nie doszacowywać sposobu cierpienia, rozmiaru cierpienia u wszystkich. I odpowiadając na to pytanie, ja myślę sobie, że w różnych gremiach musimy budować tą myśl, że jesteśmy jako ludzie złożeni ze sfer zarówno somatycznej, jak i psychicznej. I wsparcia systemowego wymagają te obszary, które wiążą się z pomocą, z profesjonalistami, ale też z budowaniem świadomości społecznej. Jest takie pojęcie jak mądrość życiowa, prawda? I to, o czym już mówili moi wspaniali przedmówcy, że nie muszą być pomocni profesjonaliści. To znaczy muszą być pomocni, ale można korzystać też z pomocy osób, które nie są tak wykształcone kierunkowo. I właściwie taką uniwersalną prawdą o ludzkim rozwoju jest relacyjność. Ja mam też taką właściwie przyjemność, że od wielu lat uczestniczę w kongresach ekonomicznych, gdzie głównie są to wydarzenia dedykowane światu polityki lub różnego rodzaju państwowym przedsiębiorstwom. I tam na jednym z paneli dotyczących zdrowia psychicznego padło takie pytanie, dlaczego w ogóle na panelu ekonomicznym mówimy o zdrowiu psychicznym? Prawda? I odpowiedź była taka, nie będzie żadnej ekonomii, jeśli państwo nie będzie brało pod uwagę zdrowia psychicznego, bo te problemy psychiczne następnie bardzo przekładają się na choroby. Także możemy powiedzieć, że tutaj różne oddziaływania, które budują świadomość, które budują relacyjność oraz które szerzą wiedzę o tym, czym jest trauma, tak jak to wydarzenie, prawda, tak jak publikacje książkowe. Ja też chciałabym, mówiąc o szczodrości, uzyskałam zgodę tutaj Państwa na to, żeby powiedzieć o tym, że jeśli chodzi o kryzys uchodźczy, nasza fundacja wydała w 2019 roku książkę, która zbiera doświadczenia niemieckie z pracy z uchodźcami i tą książką dzielimy się nieodpłatnie. Można wejść na stronę fundacji. Tam są wytyczne, czy jakby wskazówki do tego, jak Niemcy radzą sobie z kryzysem uchodźczym, jak wspierają osoby, które doświadczyły traumy wojennej. A teraz mamy w przygotowaniu publikację dotyczącą pracy z kompleks PTSD. Także w ciągu kilku tygodni się ukaże i to jest też taka forma dzielenia się, bo bardzo mi się podobało to, co pan profesor z Harvardu mówił, że istotą jest właśnie dzielenie się, prawda? A więc to wszystko, co możemy sobie wzajemnie zaoferować. Dziękuję.
Dziękuję bardzo. To, żeby kontynuując dyskusję właśnie tutaj dla Państwa, takie pytanie zarówno dla Pani Agaty i Pana Karola, jakie są skutki długotrwałego kontaktu z traumą innych ludzi? Jak to wpływa na tych, którzy pomagają?
Czy tutaj Pani Profesor
od Państwa także.
Mam też potrzebę się zaopiekować ratownikami. Już mówię, dlaczego tutaj Pani Profesor przytoczyła teraz dane statystyczne. Ja kojarzę jeszcze czasy, kiedy miałam przyjemność wykładać na Warszawskim Uniwersytecie Medycznym właśnie w sprawach dotyczących zdrowia psychicznego i wtedy lekarze, ratownicy, pielęgniarki to był jeden z zawodów wysokiego ryzyka, jeśli chodzi o właśnie sferę psychiczną, czy też skłonność do uzależnień, no wszelkie niefajne, nieprawidłowe sposoby radzenia sobie z tym stresem. Natomiast absolutnie nie wyobrażam sobie teraz tego w warunkach wojennych. Znaczy muszę sobie wyobrazić, bo gdzieś tam widzę jednostki, natomiast statystycznie podejrzewam, to jest dramat. Ja jestem w o tyle dobrej sytuacji, że w naszej organizacji w sytuacji takiego kryzysu, działania mamy taką prawie że podległość wojskową, więc ja jeżeli widzę, że któryś z moich ludzi no już przekracza swoje granice albo coś przekroczyło te granice, to ja po prostu go mogę wziąć i powiedzieć mu: teraz ty odpoczywasz, wychodzisz stąd, opuszczasz ten czas. Natomiast nie widzę możliwości, żeby tak się działo w warunkach wojennych. Pewnie też trzeba wyznaczać zmiany. Natomiast lekarze, czy też ratownicy, ale też i ratownicy, którzy w naszych strukturach działają, to jest coś, ja nie ukrywam, że z wielką przyjemnością słucham wszystkich Państwa i Pana Profesora Richarda i Pani, kiedy mówimy o właśnie rzeczach, które są niewidoczne, a tak bardzo wpływają na nasze życie, ponieważ cały czas, nawet w gronie ludzi wykształconych, w gronie akademickim, w gronie, nie wiem, dowódców, ludzi, którzy już posiedli jakąś wiedzę i doświadczenie życiowe, cały czas pokutuje to, że no tak, no to niech pójdzie na spotkanie z psychologiem. Naprawdę to są, cały czas to rośnie, ale jednostkowe przypadki, gdy załóżmy strażacy po trudnej akcji, to jest w dużych miastach, umówmy się, albo w miejscach, w których rzeczywiście, nie wiem, komendant czy dowódca jest bardzo zaangażowany i ściąga psychologa, bo zazwyczaj takowych nie ma na miejscu. Natomiast z takiej sytuacji na mojej skórze, bo oprócz tego, że jestem psychologiem, pracuję, że tak powiem, 1 na 1, to też udzielam się w służbach ratowniczych. Pamiętam sytuację, gdy 2 strażaków stało obok pani poszkodowanej, która czekała na transport do szpitala. No i tak stali z tą deską. Ja gdzieś tam wspierająca podeszłam do niej, zapytałam, czy mogę chwycić za rękę, powiedziałam jej, że tak, że już pomoc w drodze. Oni tak: a to tak można? My możemy dotknąć pacjenta? Ja mówię: no przed chwilą składaliście tutaj nogi, ręce do kupy. Ja mówię: no to za rękę chyba można chwycić, zapytać i okazać to wsparcie, a jednocześnie później otrzymać to wsparcie. Oni prosili nas o to, żeby nas jako organizację pozarządową, żebyśmy my im zrobili szkolenie, wsparcie dla ich jednostek. Także to myślę, nie wiem jak z Pana doświadczeń wynika, ale mam wrażenie, że ratownicy oczywiście są fajterzy, którzy skoczą w ogień, błoto i nie wiadomo co jeszcze, ale cały czas z moich doświadczeń wynika, że zapominają o sobie i to wymaga na pewno popularyzacji.
No właśnie, gdzie jest ta granica między pełnym profesjonalizmem, a jeszcze zachowaniem empatii i własnego zdrowia? To pytanie do Pana z doświadczeniem.
Oj, bym długo gadał, słuchajcie, bo skończyłem Akademię Medyczną w Gdańsku, jeszcze jak się nazywała Akademią Medyczną w Gdańsku wiele lat temu i 14 lat przepracowałem w Gdańskim Pogotowiu Ratunkowym. Pracowałem 14 lat na 2 etaty kontraktowe co miesiąc, więc mam 40 lat, od niedawna, a przepracowałem 28 lat etatowych, takich kontraktowych w Gdańskim Pogotowiu Ratunkowym. Ale powiem Wam szczerze, dzisiaj rano jak wstałem, mam 13-letniego syna niespełna i Zuzię, co ma 8 lat. I dzisiaj rano jak wstałem, jak co dzień, jak jestem w domu, to jak nie szkole, to poszedłem obudzić ją, powiedzieć jej cześć. Ona otworzyła oczy i powiedziała do mnie coś takiego. Zaskakujące, słuchajcie, 8-latka. I mówi do mnie tak: czy od dzisiaj będzie nam się żyło lepiej? W związku do nawiązania z wyborami, nie? Ostatnimi. A ja 8-latka. Czyli słyszę, o czym rozmawiamy, jakie są napięcia. Ja mówię do niej, że to nie jest takie proste i to jest dłuższa rozmowa, wytłumaczyłem jej i porozmawiałem, ale strasznie mnie to natchnęło na to właśnie kontakty z pacjentem, z ludźmi i w ogóle z tą mocą taką, jaką jesteśmy w stanie zrobić z tym stresem, że to jak nam będzie się żyło, pacjenci kontra medycy, na ile będziemy sobie pozwalać, to potwornie zależy od nas. Gdzie my tupniemy nogą, gdzie powiemy, że nie. Ja na przykład w pewnym momencie nie zgodziłem się w Gdańskim Pogotowiu Ratunkowym, żeby jeździć 48 godzin za kółkiem jako kierowca i fałszować dokumentację medyczną, żeby wpisywać się w 2 grafiki, jak przyjdzie w razie czego kontrola, to nie wykryją tak szybko, że medycy tak dużo pracują. Wszystko zależy od naszych granic, jak my będziemy je stawiać. Kiedyś pewna pani zapłakała w karetce, ale nie dlatego, że jest chora i że jedzie do szpitala, ale dlatego, że zostawiła psa w domu i nie wiedziała, co z tym psem zrobić. Bardziej martwiła się o tego psa niż o siebie. No ja tak siedząc koło niej w karetce w przedziale medycznym, otarłem jej łzę palcem z policzka, nie miała z 80 lat, albo my mówimy, że ktoś ma wtedy 1000 miesięcy. Tak żartobliwie, żeby rozładowywać swój stres wtedy, że mieliśmy pacjentkę, co miała 1000 miesięcy. I słuchajcie, i ta pani przestała tak płakać, ta łza przestała lecieć, ją zatkało i ona powiedziała do mnie coś takiego, ja to pamiętam do dzisiaj. Nikt nie zrobił dla mnie tak wiele, robiąc tak niewiele. I to są takie rzeczy, gdzie my faktycznie mamy moc sprawczą, gdzie możemy takie rzeczy zrobić. Kiedyś pojechaliśmy do porodu, był to 19 tydzień, pamiętam jak dzisiaj, pojechałem z koleżanką, z Moniką i na miejscu było poronienie. Już poza drogami rodnymi było dziecko, które wisiało na pępowinie, było widać, że to już jest chłopiec. I sam przeżyłem z żoną 2 poronienia, więc zawsze to jakoś człowieka dotknie, pomimo że ta skóra twarda jako medyka powinna być, to tam w środku i tak to jest kisiel mimo wszystko i kto jest świadomy, no to o tym wie, kto nie, to udaje, że jest twardy. No i słuchajcie, przestaliśmy właściwie przejmować się tym porodem tak naprawdę, tylko zaczęliśmy walczyć o życie pacjentki, bo jej się odklejało łożysko. Ona zaczęła umierać przy nas, ona zaczęła się skrwawiać. No ale mimo wszystko założyliśmy te klemy, odcięliśmy pępowinę, z zestawu porodowego zrobiliśmy małą trumnę, to ciało tego człowieka małego włożyliśmy do tej trumny i rura do akademii, tutaj do szpitala, żeby przywieźć tą panią w jak najlepszym stanie, walcząc już o życie tego dorosłego człowieka. No i nie wiem, ile cała akcja trwała, z 30-40 minut, no bo to stres gdzieś tam w tym wszystkim potworny. I posprzątaliśmy karetkę, włączyliśmy status powrót do bazy i milczeliśmy z Moniką. Pół drogi wracaliśmy, nie odzywaliśmy się do siebie w ogóle, totalnie nic. No i w pewnym momencie wpada wezwanie, kolejne zadławienie, prawda? No i ja tylko spojrzałem na Monikę, Monika na mnie, byliśmy w totalnym szoku, że ta przestrzeń w ogóle się skończyła już na tą ciszę. I zadzwoniłem do dyspozytora medycznego, powiedziałem, że jako kierownik zespołu ratownictwa medycznego zrobiłem tak pierwszy raz. Razem z Moniką nie jesteśmy gotowi podjąć następnego wezwania ze względu na mental, na głowę. I wyobraźcie sobie, że ten dyspozytor zamilkł, nic nie powiedział w pierwszej chwili, tak, a potem powiedział, dobra, to jedźcie, anulował nam tą wizytę, a później zadzwonił i powiedział, Karol, tak jak pracuję tutaj 30 lat, to ja się z czymś takim nigdy nie spotkałem, żeby ktoś odmówił wyjazdu dalszego, bo nie był gotowy. Złapali kapcia, skończyło się paliwo, zepsuła się karetka, mieli wypadek, ale stary, to o tym to tu legendy będą krążyć, że wy odmówiliście. I to jest taka historia tutaj, o której mówią też trochę panie, że jak pójdziesz dzisiaj po pomoc, to jesteś słaby. I to w ogóle to jest, nie ma przestrzeni na to w medycynie. Nie nadajesz się, skończyłeś się. Nie chcesz pracować 300 godzin, 400, chcesz tylko 200, to nie jest praca dla każdego. Jesteśmy cały czas w takim betonie, w którym wykończymy tych medyków i mamy ataki na medyków. One były zawsze, to nie jest nic nadzwyczajnego teraz, bo to nie jest, że całe społeczeństwo jest złe, bo ta frustracja rośnie. Ale po prostu tam, gdzie się pojawi dziennikarz albo kto w końcu tupnie nogą i powie, cholera, tak nie może być, my się o tym dowiemy. Ale jeżeli nie przerwiemy tej granicy, nie zaczniemy z tym coś zrobić, bo nie jest rozwiązaniem rozdać kamizelki, kuloodporne, gaz, dźwignia trójkątem, duszenie, karate, nauczyć wszystkich. Medycy nie są od tego, żeby dusić pacjentów. No, mamy mieć ogólny szacunek do siebie wzajemny i to w aspekcie tego, o co mnie pytała Zuzia, bez znaczenia, kto chce w prawo, w lewo, ale chodzi o to, że musimy mieć tą świadomość, że gdzieś jest ta granica i jeżeli dziś atakują medyków, to jutro będą atakować świadków zdarzenia. I jak tego nie przerwiemy, to niestety jest to w nas, czy my się na coś zgadzamy, czy nie, czy jest przyzwolenie. I ta granica oczywiście jest cienka. Osobiście uważam, odpowiadając jednym zdaniem na pytanie, jak ktoś pracuje 400 czy 500 godzin w miesiącu, to tej granicy nie dostrzeże.
Znaczy właśnie tu chciałam powiedzieć, że jakby wielkie brawa i dumna jestem, że Pan jest w stanie to zrobić, ponieważ ja mam doświadczenia z medykami, ratownikami, którzy są turboratownikami, Oni będą pracować 300-400 godzin, 24 na dobę, 48 na jedną dobę wepchną. I właśnie tylko, że im jak się mówi, że nie, że powinni skorzystać z pomocy albo właśnie powinni sobie wziąć urlop, no to co, ja nie podołam, to jest tragiczne. Natomiast szczerze widziałam z boku ludzi, którzy pracowali załóżmy 6 dni non-stop, no gdzieś tam śpiąc na kozetce po godzinie 2-1,5, dopóki nie było kolejnego alarmu. To nie są ludzie, to są zombie. Nie możemy oczekiwać od takich ludzi, że prawidłowo wykonają swoje zadanie, bo w tym momencie to już jest tylko taki automat do powtarzalnych czynności. Natomiast tam granice to już zostały przekroczone bardzo dawno. Tylko jest pytanie, na ile właśnie my sami w sobie
czy
potrafimy
na ten
postawić te
temat
granice,
rozmawiać
powiedzieć, nie, już nie
w
mogę
różnych
pomagać, jestem sam niewydolny, potrzebuję pomocy. Bo to jest bardzo ważne, chociażby pewnie się Pani zgodzi w zawodzie terapeuty, no my mamy obowiązek mieć superwizję i to ten człowiek, który nas słucha, mówi nie, tutaj nie na przykład, albo nie wiem, zrób z tym coś innego. Być może gdyby taki mądry supervisor był u ratowników i wziął ich za fraki i powiedział nie, ty dzisiaj nie.
No właśnie, jak wygląda dyskurs w Państwa zawodach?
Znaczy, ja bardzo dziękuję za to, co Pan powiedział, bo zilustrował Pan takie zjawisko, że istnieje potężna presja wobec zawodów medycznych i to presja taka i zewnętrzna, jak i wewnętrzna, prawda, że ja muszę działać, muszę zdążyć przed śmiercią, muszę być skuteczny i wydolny. I ja myślę, że to jest ogromne obciążenie, że to może nawet przybierać taki kształt również takich społecznych oczekiwań, że służby czy medycy to takie robotyczne istoty, prawda? Jak gdyby pozbawione tego oddźwięku emocjonalnego. I przede wszystkim to ja myślę, że to szapoba, że Państwo byli w stanie się przeciwstawić systemowi i powiedzieć, moje limity zostały przekroczone w tym momencie. A więc to jest też jak gdyby nasze narzędzie, prawda? Narzędzie dbania o siebie i dbania o innych. I ważna jest tutaj zasada ta sama, która obowiązuje w samolocie, mianowicie najpierw zapnij pasy sobie, a potem dziecku, prawda? Bo jeśli medyk czy pracownik służb nie będzie w stanie zadbać o siebie, nie będzie w stanie pomóc, prawda? I to samo dotyczy systemu. I jeszcze wspomniała Pani o superwizji, też myślę, że to bardzo cenna myśl. I ja myślę, że nasi przedmówcy mówili o tym, że nie ma możliwości, aby uniknąć traumy. Wszystkich nas traumy dopadną, choćby związane z procesami rozwoju życia, starzenia się, utraty zdrowia. To wszystko są traumy. I to, co jest taką świadomym sposobem obchodzenia się z tym faktem, to, że ja mogę pracować nad tym, nie żeby unikać traum, tylko żeby radzić sobie z traumami, żeby budować wewnętrzne narzędzia i wewnętrzne kompetencje do tego, aby być wydolnym, aby nie chronić się obsesyjnie. I ta budowa, do tej budowy możemy podejść na różne sposoby, tak jak do budowy domu. Możemy kupić z gotowych elementów i w 3 dni postawią, a można też cegła po cegle, prawda? I ja myślę, że właśnie to każdy chyba z nas musi sobie odpowiedzieć, jak ja w ten swój wewnętrzny dom inwestuję, bo inwestujemy ucząc się, czytając, budując sieci relacji, budując sieci zaangażowań, dzieląc się, prawda, korzystając z superwizji, korzystając ze szkoleń, idąc na psychoterapię. Mamy też sporo lekarzy w terapiach, co jest wspaniałe, że widzą, jak ważna jest ich kondycja i ich wydolność.
Także mamy wzorce, z których możemy czerpać. Te dobre wzorce oczywiście.
Absolutnie, ale to zależy od naszego zaangażowania, prawda?
Także dziękuję bardzo. Jeszcze może ktoś z Państwa miałby ochotę zadać pytanie z publiczności, skorzystając tutaj, że mamy ekspertów. Jakiś... O, dobra. Proszę bardzo.
To ja w takim razie, jeśli mogę zadać pytanie, mam może do pań reprezentujących, jakby to można określić, organizacje pozarządowe, prawda? Czy widzą Panie jakąś rolę organizacji pozarządowych w takim właśnie przygotowywaniu społeczeństwa do potencjalnych traum? Niekoniecznie to musi różnego rodzaju, prawda? Nie wiem, społeczeństwa na obszarach, gdzie występują powodzie, prawda? Bo wiemy już, że są przecież takie oczywiste, że regiony w Polsce i tak dalej. No, zagrożenia wszelkie geopolityczne i tak dalej. Czy w oparciu o Wasze doświadczenia coś takiego powinno się dziać? Jakieś wykorzystanie właśnie Waszych doświadczeń w przygotowaniu społeczeństwa, a jeszcze w kontekście tej polskiej specyfiki i ustawy o obronie cywilnej, prawda? Dziękuję bardzo.
Jeśli mogę, powołał się Pan na ustawę, która nas bardzo dotyczy w tej chwili. Polski Czerwony Krzyż lobbował za tym, żeby takie przygotowanie musiało mieć miejsce, ponieważ tak jak mówiłam wcześniej, przygotowane społeczeństwo, świadome społeczeństwo dużo lepiej poradzi sobie z kryzysem niż społeczeństwo, które nagle zostaje wyrwane sprzed ekranów telefonów i na przykład, nie wiem, ja już nie mówię o tym, że nie wiedzą, gdzie się zgłosić po pomoc, ale żeby jakoś zaopiekować siebie, gdzieś bliskich wokoło, także to jest olbrzymia rola organizacji pozarządowych. No, my gdzieś tam staramy się podejmować takie działania na terenie całego kraju, przygotowywać ludzi do kryzysów, pokazywać jak się przygotowywać, jak być gotowym na ewakuację, czego się spodziewać, czego się bać, a z czym sobie radzić, kogo się słuchać, bo to naprawdę w tej chwili poziom dezinformacji też jest tak wysoki, że ludzie wszystko lepiej wiedzą z, nie wiem, TikToka, a nie znają podstawowych, nie wiem, sygnałów alarmowych, więc to rzeczywiście może się okazać i w takim przykładzie, który Pan poruszył, powodzi. Lokalna, na szczęście lokalna trauma, kryzys, natomiast tam, nie wiem, 1,5 dnia prądu nie było, zanim nie przyjechały duże generatory od wojska i to był totalny chaos, kryzys i bezprawie. No to co się działo, to oczywiście gdzieś tam udało się zapanować nad tym, natomiast ciężko mi wyobrazić sobie, że gdyby, załóżmy, Gdańsk dotknęła, nie wiem, 1,5 dnia bez prądu, to co by się tutaj działo, to ja polecę, gdzie są schrony, bo naprawdę jestem trochę porażona przygotowaniem społeczeństwa do tego. Także myślę, że rola organizacji pozarządowych jak największa, bo nie bardzo wiem, kto miałby jeszcze to zrobić. No, policjanci po domach raczej chodzić nie będą, a myślę, że gdzieś tam status, jakim możemy się szczycić, pozwoli na pewne zaufanie społeczeństwa, że to nie jest, nie wiem, jakaś nagonka, tylko to jest działanie w imieniu ich dobra i dla ich przyszłości.
Jeśli mogę jeszcze się podzielić, ja zaczynam swoją karierę zawodową od uczelni, ale nie rozwijałam się, zrezygnowałam i zaczęłam się uczyć psychoterapii. I czuję po prostu ogromną radość, że dziś tu z Państwem jestem, bo mam takie poczucie, że zatoczyłam koło. I w radzeniu sobie z traumą, tak jak uczymy w naszej fundacji, to często powtarzamy słowo integracja. Organizacje społeczne są pewnym zasobem, który może być zintegrowany z innymi zasobami. I widzę to właśnie w ten sposób, że mamy łączące idee, prawda, że na przykład idziemy na wydarzenia, gdzie są politycy, czy gdzie są medycy, gdzie są uczelnie i nie budujemy barier, nie budujemy granic, tylko łączymy się i ja myślę, że to wtedy społeczeństwa będą silne, bo ja myślę, że zarówno uczelnie, jak jak i NGOsy, jak i wszelkie inne zasoby społeczne mają swoją ofertę, prawda? I tylko wtedy ona będzie optymalnie wykorzystana, kiedy ona będzie integrowana z innymi aktywnościami.
To ja myślę, że nie ma innego wyjścia, bo ja nie wyobrażam sobie sytuacji takiej, gdzie załóżmy Polski Czerwony Krzyż ze swoimi zasobami, nie wiem, wjeżdża gdzieś na 2 tygodnie i buduje nowe państwo. To nie tak działa. My jesteśmy jako organizacje wsparciem dla systemu, który musi sprawnie działać. Państwo, grono naukowe, akademickie, że użyję słowa, musi udowadniać, że to ma tak działać. Jakby, jeżeli zbudujemy ten system z takich połączonych trochę naczyń, trochę cegiełek, ten dom, w którym każdy znajdzie swój pokój dla siebie, to tylko w ten sposób to będzie działało sprawnie. Jeżeli my możemy być jakimś łącznikiem społeczeństwa z systemem, to będziemy się starać to robić i dawać i wspomagać. Natomiast to, na czym nam zależy, to to, żeby ta społeczność, nieważne czy to będzie w granicach państwa, miasta, województwa, sama sprawnie działała. My możemy pokazywać ścieżkę, otworzyć jakieś drzwi, połączyć systemy, natomiast na pewno nie budować mury. To nie, to wręcz odwrotnie.
Ja mam takie jeszcze jedno zdanie, właściwie kilka. Uważam, że powinniśmy zacząć ponownie myśleć i przejąć władzę nad swoim mózgiem w obliczu telefonów i komputerów, które nawet tabliczkę za nas pamiętają mnożenia, a nie wiem ile z Państwa zna numer telefonu na pamięć, 1 albo 3 chociaż jakieś, bo wszystkie urządzenia nas wyręczają. I śmiem twierdzić, że kompetencjami przyszłości będzie czytanie ze zrozumieniem, słuchanie ze zrozumieniem, co jest trudniejsze, bo z mózgu daleko jest, z ucha do mózgu i często to się gubi, tam cofa. I odróżnienie, co już padło, co jest kłamstwem, a co jest prawdą. By odnaleźć się w tym życiu, co jest taką wartością, gdzie nas robią w bambuku, a gdzie widzimy gdzieś tam jakąś wartość. A przede wszystkim człowiek, który jest do czegoś przygotowany, będzie sobie z wieloma rzeczami później radził lepiej. Więc umiejętność obsługi gaśnicy, umiejętność obsługi apteczki pierwszej pomocy, posiadanie apteczki pierwszej pomocy w samochodzie koło nogi, ani w bagażniku. W polskim prawie nie ma obowiązku posiadania apteczki w samochodzie. No w jakiej realizji, że mamy obowiązek udzielania pierwszej pomocy, a nie ma obowiązku posiadania apteczki w samochodzie, pomimo że ona jest. Lekcje w szkołach, które będą ciekawe dla dzieci, które będą uczyły ich kompetencji koniecznych, kompetencji obowiązkowych, jak pływania chociażby, nie po to, by zostać mistrzem maratonu, ale by utrzymać się 2-3 minuty dłużej na powierzchni wody, zanim przybędzie może ten dron, który niedługo będzie pływał po tych ludzi zamiast Davida Hasselhoffa, zanim koszulkę ściągnie i pierwsze włosy wbiegną, prawda, do sali. Tutaj chyba taki jest duży. Ale chodzi o to, że musimy uczyć się konkretnych rzeczy, jak obsłużyć pleck ewakuacyjny, jak odpalić gaśnicę, jak włączyć butlę z gazem albo jak ją zakręcić, bo to jest coś, co jest tak naprawdę ważne. I może jak wtedy będziemy sobie z takimi drobnymi rzeczami potrafili poradzić, to te traumy, które nas spotkają, bo to jest kwestia czasu, które nas spotkają, to może być wypadek komunikacyjny, nie ma problemu, kogoś stracisz. To nie może być tak, że ty umrzesz w konsekwencji złej wiadomości, albo że dostaniesz choroby psychicznej, czy już przestaniesz się odzywać, bo usłyszałeś coś strasznego. No, musimy nad sobą pracować, ale bardzo dużo mamy takiego szlamu wokół siebie, który musimy przepuścić przez takie naprawdę wartościowe sito.
Jeśli można jeszcze zdanie, to bardzo ważna kwestia, bo to dotyczy zagrożeń związanych z używaniem nowoczesnych technologii, ponieważ okazuje się, że w związku z korzystaniem z technologii mózg ludzki ewoluuje i ludzkość się zmienia i my jako ludzie stajemy się mniej inteligentni i mniej empatyczni. A to jest zagrożenie. A więc to Pana zdanie, że używajmy mózgu, jest naprawdę nawet uzasadnione badaniami naukowymi i głęboko prawdziwe. Jest nazwaniem, myślę, że ważnego ryzyka, które nas dotyczy. Dziękuję.
Halo? Do Pani Gajos. Jaki jest zakres Czerwonego Polskiego Krzyża w budowaniu tych relacji, kolaboracji w tej podzielonej Polsce?
Zakres, ale pyta Pani o terytorialny, o to, co możemy
nie,
zrobić.
z tych wszystkich organizacji to widać, że z daleka, że Czerwony Krzyż, prawda, na całym świecie jest tą organizacją, w którą wszyscy wierzą, ufają, wspomagają, dają pieniądze, otwierają drzwi, prawda?
Staramy się. Znaczy ja myślę, że to polega na zakres. To jest bardzo trudne pytanie, ponieważ każdy z nas, jakby 99,9% może oprócz głównych księgowych, to są wolontariusze w Czerwonym Krzyżu. Także każdy trochę przez swoje doświadczenia, status zawodowy, społeczny stara się wpływać na różne aspekty życia i torować tę drogę do jak najszerszego i udzielania pomocy, bo że tak powiem, mamy zasoby ratownicze i mamy zasoby pań z koła seniora, które zajmą się dziećmi w razie potrzeby. Także ja myślę, że ten zakres jest od prób lobbowania politycznego za dobrymi i skutecznymi rozwiązaniami do bardzo takich lokalnych działań. Więc a to, że ci ludzie działają, bo chcą, to myślę, że to być może otwiera serca i to, że jesteśmy taką rodziną, że jak wjechałam na parking w Berlinie, szukając miejsca i ktoś tam zobaczył kamizelkę z Czerwonym Krzyżem w samochodzie, mówi, nie, chodź tutaj, będziesz miała za darmo na naszym parkingu, więc być może to jest taka rodzaj empatii po prostu międzyludzkiej, a jednocześnie ludzi, którzy są w różnych miejscach i starają się wpływać na to, żeby to nasze społeczeństwo mogło jak najwięcej czerpać, samodzielnie używać mózgu, gaśnicy, z tego też się i naszych podopiecznych szkolimy, co wcale nie jest takie proste, zgaszenie wanny z olejem na przykład.
Szanowni Państwo, niestety czas nas goni nieubłaganie, a dyskusja nam się tak ładnie rozwija, więc mam nadzieję, że możemy ją w kuluarach kontynuować. Natomiast oficjalnie ja muszę Państwu bardzo podziękować jeszcze raz za wkład i inspirujące dyskusje, tematy i w sumie bardzo dobre podsumowanie. Używajmy mózgu.
Proszę Państwa, nasza konferencja dobiega końca, ale jest to, myślę, miejsce na pewne krótkie podsumowanie i też przede wszystkim na podziękowania. Ja przede wszystkim chciałem podziękować wszystkim i wykładowcom, panelistom, moderatorom także za to, że stworzyli pewną przestrzeń zarówno do naszej inspiracji. Ja czuję się zainspirowany. Widziałem też, że wiele było dyskusji w kuluarach, wiele osób się nagle spotkało gdzieś tam po jakimś czasie, ponownie odwiedziło na przykład uczelnię. W związku z tym to jest taką przestrzeń, którą chcemy zawsze. Ja ze swoim zespołem staram się, żeby nie tylko była merytoryka, ale żeby była jeszcze przestrzeń do spotkania, przestrzeń do dyskusji i poznawania się, więc z Państwa min, że dość dużo osób zostało na sam koniec, to jednak to chyba świadczy o tym, że nam się to choć trochę to udało. Także ja się cieszę także, że temat traumy, szczególnie w perspektywie zdrowia publicznego, jako szef Zakładu Zdrowia Publicznego mówię, że nie można patrzeć na zdrowie tylko z perspektywy indywidualnej, chociażby musimy budować systemy, które są odporne. My musimy inkorporować podejście, dbanie o zdrowie psychiczne właśnie do naszych systemów zdrowotnych, nie koncentrować się tylko na tym aspekcie fizycznym. Także wydaje mi się, że to się też tutaj udało i dzięki temu możemy o tym rzeczywiście w szerszym zakresie mówić. Tutaj już niestety nie ma z nami Tita Albrechta i Juty, ale chciałem tutaj wyrazić dla nich podziękowania za to, że powierzyli nam to zadanie, dość w krótkim terminie zrealizowane, ale chyba też z sukcesem, za to, że ta kolejna konferencja i zaraz po niej następująca tygodniowa szkoła letnia związana właśnie ze zdrowiem psychicznym, w tym ujęciu zdrowia publicznego, odbywa się tutaj w Gdańsku, także wielkie podziękowania. Ja natomiast szczere podziękowania i największe chciałem tutaj skierować do mojego zespołu, który się podjął tego zadania, bo ja powiedziałem od razu, że słuchajcie, ja będę kibicował, ale wiecie, taka konferencja to ktoś musi zorganizować, dlatego przede wszystkim chciałem tutaj 3 osobom szczególnie podziękować. Na początku Agnieszce Wojteckiej, która rzeczywiście tutaj skoordynowała wszystko, także Agnieszko. Tak, Agnieszka naprawdę tutaj poświęciła wiele tygodni, wiele miesięcy tutaj swojego życia. Drugą osobą, którą chciałem także wyróżnić, jest Agata Konieczna, która także tutaj na tym zapleczu tutaj wszystko organizowała. Plakaty, ulotki, materiały, maile, które Państwo dostawaliście, to także... I trzecia, ale nie najmniej ważna osoba, to jest tutaj nasza Beata, która powoduje, że wszystko tak pięknie wygląda. Słuchajcie, że są fotele, że nawet kwiaty. Tutaj uczelnia miała problem z tym, żeby kwiaty postawić, a mówię, że musi być ładnie, musi być miło, bo to jest fajne wydarzenie. Beatka załatwiła te kwiaty, także i ten catering i wszystko, także wielkie podziękowania, Beatka. I już na końcu chciałem podziękować, bo to był też większy zespół, także studenci byli tutaj w trakcie konferencji zaangażowani ze Studenckiego Koła Naukowego Zdrowia Publicznego, nasze stażystki, także cały zespół zakładu tutaj się bardzo mocno starał. Także proszę Państwa, kończymy naszą konferencję. Tu jeszcze będzie wyświetlony QR kod do wypełniania ankiety, będzie też rozesłany, bo bardzo nam zależy, żebyście Państwo nam dali feedback, co się udało, co się nie udało, może co powinniśmy poprawić. Chętnie byśmy stwarzali taką przestrzeń do dyskusji właśnie pomiędzy akademikami, profesorami z Gdańska, profesorami z Harvardu, a też praktykami, którzy rzeczywiście się tymi tematami zajmują. Także wielkie dla Państwa podziękowanie za obecność. Jeżeli dacie nam feedback, będziemy wiedzieli, że powinniśmy częściej takie eventy organizować. Także oficjalnie uważam 6. konferencję Trauma Informed Public Health za zamkniętą. I dziękuję Państwu bardzo za udział.